the KSM can rest assured that it will reach new heights under your leadership, sir. And now we shall begin today's academic program. The symposium will begin with a session on history of sepsis, which will provide a strong foundation to the rest of the day. Our first speaker is Dr. Mudita Bekon, who is a consultant clinical microbiologist at National Hospital Kandy. He will be talking on the topic sepsis history. This invitation is due to sir.
Good morning to all of you. Actually, I'm going to talk about the sepsis, the history of sepsis, but it is not about the recent history about the sepsis definition and the new development after 1990. This is about the ancient history, and as you all are aware, I'm not going to touch the technical details or the technical things we have learned. I think my colleagues will deliver on the technical things, the definition changes and the new advancement in the management of sepsis. This is just to glance at the history of the sepsis and the evolvement. And I think when I was preparing this lecture, I was quite amazed to see some of the misconceptions we had in early centuries. And once you got a misconception, especially from a prominent figure in medical field, you will see it is quite difficult to eradicate. When we talk about sepsis, it has happened for many years, and due to that, actually a lot of patients has died. So having a smart brain and having common sense, even in the medical practice, it is going to be very important. As you all are aware, sepsis. I'm just start on the definition. It is a life-threatening organ dysfunction. Life-threatening organ dysfunction due to a dysregulated host response to an infection. So when I'm going to talk about the history of the sepsis, we have to talk about two things. One is we need to see whether they have talked, the ancient people, whether they have talked about the sepsis or whether they have talked about an infection. So it is quite clear, if you go through the history, you know, in medical literature or even in some other literatures, there are evidence that they have mentioned about infections. They have mentioned about very serious infection. One of them is the Black Death or the plague, right? It is quite amazing to see how many people have died due to plague in ancient times. But unfortunately, during these eras, until late 19th century, no one could present the germ theory. So they knew something wrong and the rats are spreading the disease, but they couldn't attribute it to a germ. So you can see, I mean, millions of people have died due to plague, and even if you go into the normal literature, there are a lot of famous novels which has, I mean, there are a lot of famous novels has written during these epidemics, and one is The Plague by Albert Camus. And even you can see the smallpox has killed a lot of people. slide එක නෝ මෙතන මූව් වෙන්නේ off කරලා ආයෙ බලන්න presentation off කරන්න so you can work on that. You might look at yeah, that's fine. So this is the death toll due to the epidemic. So due to the infections we had in ancient history. So you can see due to plague that is in 1347 to 1351, 200 million people have died due to plague, and even there are some other epidemics after that. Even plague has killed so many people. So just coming into this 200 million people, actually one civilization has totally disappeared due to plague. And if you go to the Buddhist history, even in the Buddhist literature, it has mentioned a disease called ahivataka, which means the disease is derived from a huge cobra. And you also know, it says in Buddhist literature, once a person go into the Himalayan forest, they contact the disease, and once they come to the village, it rapidly spread, and the people who has fled from the village, the one only who have survived. So even in the ancient history, even in the literature, there are a lot of things we can find about infections. So what is the meaning of sepsis? The sepsis is actually a Greek word which called sipo, and it means decomposition of animals or vegetable organic matter. But unfortunately, if you go to the history, the medical literature, it doesn't say about sepsis, but it talk about infections, and especially it talk about wound infections. So if you want to elaborate on the history of sepsis, actually mainly it is about wound getting infected and those patients going into septic shock, but they didn't have the knowledge to correlate the urinary tract infection leading to sepsis and the pneumonias leading to sepsis. But it is all about wound infection and sepsis, and they hardly use the word sepsis before 20th century. And even the great philosopher Hippocrates has mentioned about sepsis. So the germ theory was not there at that time, but he thought as consequences of harmful products derived from the colon can lead into sepsis like thing, but he hasn't used the word sepsis. So the word sepsis is in the Oxford English Dictionary since 1858. But after the germ theory, which was invented by Robert Koch and also by Louis Pasteur, the terminology related to sepsis has markedly improved. So in medical dictionary in early 90s, you can see the word like septicemia, pyemia, and also the terms like sapremia. So if you talk about the sepsis in ancient Egyptian period, so even that time they knew infections can cause the death of people, but they couldn't attribute it to the sepsis. And they have mentioned in several of the described cases, the presence of pus as a secondary and late phenomenon is described and associated with a bad prognosis. And I have told about the Hippocratic, and there is another guy called Galen, and these medical practitioners or philosophers we can find during the Greek ancient time period. So it is quite interesting to see the Hippocratic has observed when a cut become inflamed, the neighboring tissues become intermittent and the lesions will become flushed and heat spreads through the vessels. If the lesion is located in the leg, the tumor will develop in the groin, and if it is in the arm, they will prefer the armpit. Though they couldn't interpret or though they couldn't find out the scientific basis of sepsis at that time, but they were very good observants, and I think you can clearly see he has described about the inflammation and also the local spread to the lymph node once a wound get infected. So this is a famous Greek philosopher called Galen, but unfortunately he is one of the greatest philosophers during the Greek era. So he is the one who has found most concepts of anatomy, but unfortunately due to one of his bad observation, actually the evolvement of sepsis has delayed for many decades. That is due to this. So he has observed some of the wounds after the infection, the wounds are accumulated with pus, and there are some of cuts or some of abrasions you can't find out pus, but they are very rapidly spreading, and usually these patients die rapidly. So he thought accumulation or development of pus in a wound is a good sign, and not development of pus in a wound is a bad sign. So what he has done, according to his theory, all the abrasions or all the wounds, he artificially tried to develop pus in the wounds, adding very hot boiled water into the wounds, because he thought creation of pus in wound is actually a good prognostic sign. But with the modern knowledge, we know this is a very mild infection, right? Usually it can be due to Staph aureus like organisms, where it causes local suppuration, and later due to the response of our immune system, these patients automatically recover. And we know the group A streptococcus like organisms can, due to their toxins, they won't produce pus, but due to the toxin, these patients can die rapidly. So this observation, actually the Galen, what he has done is he wrongly interpreted that the formation of pus is a good prognostic sign. Because of this observation and because of his renownedness, this wrong concept has practiced for many years, actually for 1,000 years, and lot of people die due to this. So this is the practice he has carried out during that time period. So even from the Roman time period to the medieval age, still the wrong practice was carrying out, because nobody dared to challenge his observation. And luckily, one of the clever surgeons during the late 16th, he was the first person to challenge this misconception, and actually it has happened very accidentally. So in his word, he says, so the usual practice was to, when there is a patient with a wound, they try to boil the wound, they try to injure the wound with a boiled oil. So he has said at the beginning, first before I applied it, what other surgeon did for the first dressing, which was to put the said oil boiling well into the wounds with tents and satins. Wherefore I took courage to do as they did. At last my oil ran short, and I was forced instead therefore to apply a digestive made of the yolk of eggs, oil of roses and turpentine. In the night I could not sleep quiet, fearing some default in not cauterizing, that I should find the wounded to whom I had not used the said oils dead from the poisons of their wounds, which made my rise very early to visit them, where beyond my expectations I found that those to whom I had applied my digestive medicament had but little pain, and their wounds without inflammation or swelling, having rested fairly well that night. The others to whom the boiling oil was used I found feverish, with great pain and swelling about the edges of the wound. So we all know about Alexander Fleming finding out penicillin, and what a marvelous revolution he has done for the medical field. But quite sad to say, in my opinion, this observation is one of the greatest observations in the medical history. So since this observation, this young Peary, who regarded as the father of surgery, he was only 26 years of age at that time, abandons using boiling oil on wounds. Even though Peary himself continued being reluctant to the surgical exploration of wounds and only perform it when he was going to pull out foreign bodies and fragments of bone, but he was pioneered in discarding the very old wrong practice of Galen. I think, as I said before, they knew something wrong with these germs, but they couldn't show it. During that time, actually the theory was miasma theory, so they thought something coming out of, when organic materials are putrefied, something coming out as a fume will cause these diseases, the cholera or even plague, because they couldn't show us that germs or the bacteria exist. But during late 80s or during the early 19th century, the Robert Koch and also Louis Pasteur and Ignaz Semmelweis, those are the persons actually who contributed to this germ theory. So since then, we knew these infections are coming from tiny bugs which can only be seen under the microscopes. So that is the second turning point regarding the sepsis. So for many ages, we were actually groping in the darkness without finding the real cause. So what are the things we have learned from studying ancient history? It took ages to find out the main reason for sepsis. After the germ theory, there is a huge progression in the field of sepsis which have saved millions of lives. However, despite these advancements, are we still groping in the dark? That is the big questions we are having, and I think we have very distinguished speakers to give an answer to this. So you can see, about 1000 years ago, we were definitely groping in the dark without finding the theory behind sepsis. Even now, as far as I know, there is no definitive treatment for sepsis. I know there are a lot of antibiotics to treat infections, but once the patient is in septic shock, still there is no definitive treatment to cure patients with sepsis. There is no definitive treatment. We have a lot of supportive care. So I think it is over to you to elaborate on the newest development in sepsis, which is very important. Thank you very much.
Thank you very much, sir, for providing an understanding of evolution of topic of sepsis.
That is being sorted out. There's another small announcement. We can distribute a new membership form joining KSA. So the live membership for KSA is only 3,000 rupees. Live membership. And anytime, so if you are a member of KSA, anytime you come for a paid session done by KSA, like the annual session to dinner or some other program here, you will get 25% discount. So your membership will get a covered in that new session. So these days, membership, so lots of people are coming to KSA, attending KSA, working with the KSA, but I'm not really there. Maybe KSA so close, you don't know that they are member or not. So we are issuing some forms. Please fill those and give answer. If you do not have money, then only money tomorrow. Fill the form today.
Ladies and gentlemen, sorry for the inconvenience caused by technical difficulties. I would like to invite Dr. Madhuri Jayasinghar, consultant physician, National Hospital Kandy, to present the certificate of appreciation to Dr. Muthu Abhinkam. Thank you, Dr. Kundi and Jayasilhan. We shall now move on to the second session for the day, which will be an interactive case-based discussion on initial management of septic shock. The speaker for this session is Dr. Ganaka Senaratta, who is a consultant physician at Emergency Treatment Unit of Teaching Hospital, Karachi. Over to you, sir.
මට දාලා දෙන්න අර මොකක්ද මෙතන percentage percentage නෙමෙයි අර පස්සේ දෙන්න duplicate එක නිසා හරිනේ right good morning all of you. Good morning, all of you. Thank you very much, Professor Saman Anakara and Kandy Society of Medicine for inviting me for this talk today to share some of my views on sepsis. And I shall thank my dear friend Mudita, who brought me all the way from Goa to talk to you today. It gives me a great pleasure to come and share my thoughts with Kandy crowd, whom I have a lot of teachers, my colleagues, friends and medical students. So it's a special moment for me. I really appreciate and I'm really humbled and honored for this invitation. Thank you so much. I would try to take you all through this interactive session through Slido platform. Before we move into the talk, may I ask you to take your phones out and try to turn on your data and search for slido.com. Go to the Google bar and search for slido.com, and then it will ask whether you like to join as a participant, and in that place please enter this code 41705661. Once you enter this, you will enter into the Slido, and then next step I'll let you know when it should be done. You will be asked to enter your name, and then you can enter to this particular presentation later on in a minute, I would say. Okay, hope that you all are now in Slido. So to make you familiar with this platform, I'll run very few basic day-to-day 2 questions, and to see whether you got this platform in operation in your mobile phones. All right, ready? Right. Right, you can see this picture. I'll ask a very simple question out of this. Keep remember this picture. Now enter your name. So we should see people joining in this board. All right, very good. There are 3 people. Okay, it's going. So we'll wait for about 30 seconds until everybody join with the Slido and the presentation. 21, 30. How many we have? We have about 50, 60 people. You can scan this QR code as well if you want to. Okay, right. The first question is, what is this place? Is it Dalanda Maligawa or National Museum? Please select the answer in your phone. Select and submit. So 30 people have answered already. Good. 40. Right. Okay. Let's see what's the correct answer. It has to be Dada Mariga, isn't it? Well, 2% have said it's National Museum. Uh, that is the case. I mean, we think that we know everything, but there are very simple facts that we might not know. So it was the case with sepsis, I guess, as Mudita said. So we'll try to move on. Uh, you can see this picture. I hope everybody know this guy. The question is, who is this cricketer? Is it Dasun or is it Dimuth Karunaratne? Please answer. Do you see? 96% believes it's Dimuth Karunaratne, which is the case. He's a test captain who is playing brilliantly well in the ODI series as well. But 4% believes it's Dasun. Alright, okay. Right, ladies and gentlemen, now we are ready for our interactive case discussion on early management of sepsis and septic shock. Okay, you are getting a call from the ward. There's a patient, a lady was brought in feeling with unwell and faintish for 1 day. At the admission counter, these are her numbers. Respiratory rate 26, saturation 96, heart rate was high, blood pressure was low, and GCS was 15. And nurse wants you to come and see this patient. Please come and see. So this is the call that you are getting. The question is, what is your thought process while you are receiving this call? Patient is stable, so I can see her after finishing my routine duty. Or patient is unstable, so I need to rush and run to this patient and see. Please answer. The correct answer is patient is unstable. 97% believes patient unstable, 3% believes patient stable. Well, she is unstable, so why we need to go and rush and run and see these patients and manage them? What happened to unstable patient is that we need to know what it does. So we need to understand the interplay between pathology and physiology here. When you start a pathology, let's say you get a bug into a Streptococcus pneumonia, let's say into your alveoli, you take some time for you to get a notice. Even though it starts inflammation right from the word go, take some time, maybe days or weeks, and then you get some symptoms of pathology like phlegm, cough, fever, something like that, isn't it? But if you don't take any treatment at that point, what will happen is in couple of days time you might feel SOB, isn't it? That is because the inflammation has obstructed the oxygenation process, making you hypoxic. So you will get your symptoms of altered physiology, that is hypoxia. So that's a different set of symptoms. You had initially symptoms of pathology, now you have symptoms of altered physiology, SOB, faintishness, unconsciousness, drowsiness, blah blah blah. So those are symptoms of altered physiology. If you don't do anything at that point, how long you could live? Well, we know in hours time you will be really deteriorating into maybe multi-organ failure or maybe even cardiorespiratory arrest, isn't it? In hours or maybe minutes. And at that point, once arrest happen, you have few seconds to live, maybe few seconds to 5 minutes. You will be confirmed brain dead after some time, isn't it? So that is why this period, particular period, is very rapid. It's like a highway, very rapid. That's why you call it golden hour. Once your physiology is affected by the pathology, it's like a highway. You're gonna go and deteriorate yourself. That's why we call it golden hour. That's what someone said, it's golden hour. And at this golden hour, you need to have a way of managing this patient. That's what we call blueprint. You see it in this the left corner. You need to triage these people. You need to catch people who are unstable and call for help, and then stabilize the physiology first by ABCDE, and then focus assessment of pathology. Once the physiology is stabilizing, you go and assess the pathology by history, examination, investigations, and then start treatment for pathology. That's what you do for an unstable patient. Right, what is your goal at this stage? Let's say this patient is now, our patient is having low BP. Start immediate treatment for pathology or prevent imminent arrest. Please answer. Okay, let's see. Yeah, majority believes the patient we need to prevent imminent cardiorespiratory arrest. Why? Because her physiology was unstable, isn't it? That's the correct answer. So how do you do that? You do it by stabilizing the deranged physiology. What is the meaning of the word resuscitation? Resuscitate is a Latin word. It means pull back, bring back. So that is, you are going to bring back the physiology again. So how do you do that? You do it by this wonderful tool ABCD. So the ABCD assessment of our patient, airway was better, she could talk, and breathing was normal, main lip saturation 96, respiratory rate was bit high, but no abnormal breath sounds, and she has central trachea and everything, but she has abnormal circulation, low blood pressure, high heart rate, warm peripheries, kind of thing. And disability was all right, and exposure showed high temperature, but no bleeding, no rashes or nothing. So we were able to correct these things then and there. We started her on oxygen. Fluid resuscitation has been started by 2 wide bore cannulas and giving her crystalloids. Bloods taken for cultures and other investigations done. With the fluid, with the oxygen, she was a bit better. Her blood pressure was start to come up to 85, 86, somewhere around there. So what ABCD does is stabilizing the deranged physiology and prevent cardiorespiratory arrest, and it buys time for you to assess your pathology. And not only that, it gives you clues for the pathology as well. You can guess what the pathology this patient is harboring at the stage of ABCD. Right, what is the possible pathology of this patient? Cardiogenic shock, hypovolemic shock, septic shock, anaphylactic shock. So you got some clues. Yes, majority believes septic shock because she was on shock and she has temperature. So it's most likely septic shock. Had she had the urticarial rash, it might be anaphylactic shock, isn't it? So likewise, you can get a clue. What is the better criteria to screen for sepsis on admission? Is it SIRS or is it QSOFA? Majority believes it's Q so far. Well, let's see the answer. It's SIRS actually. Now, Mudita was describing things from Gallen's period, and I'm trying to take you to the 2021 Surviving Sepsis Campaign guideline from Gallen to 2021. Now we believe, well, in 2016 we believe it's Q so far was the best thing, but according to the lot of comparative trials and systemic reviews done after that, this is SIRS and QSOFA criteria. It's believed that SIRS, MUSE and EWS are better than QSOFA in detecting sepsis. But QSOFA is better for predicting the mortality. So therefore, now we use SIRS and other scoring systems other than QSOFA. That is one new change in 2021. Right. Now with this clue in our mind, we have stabilized this patient. Stabilizing, we go for assessment of the pathology. We start from focus history. She was a 52 years old lady, diabetes on insulin, had dysuria for 5 days, and she had fever, back pain for 3 days, and getting dizzy when standing for 1 day. So what does this mean? She has some urinary tract infection, and now she is dizzy because of hypotension, isn't it? Examination revealed warm peripheries, looking ill, and renal angle tenderness. So this had more evidence for the diagnosis. We did some focus investigation, inflammatory markers, ABG, cultures, point of care sonography. I'll take you through one by one in later slides. ABG shows pH of 7.19 and lactate was 4. So we took it as lactic acidosis. So at the end of the ABCD and focus assessment, ladies and gentlemen, what's the diagnosis? So SIRS, if you go through SIRS, she had 3 criteria. Temperature was high, heart rate was high, SBP was less than 90. So she was SIRS positive. So likely sepsis, and her lactate was more than 4, blood pressure was low. So it looks like she's on septic shock. Why? Because of fever, dysuria, back pain, that signifies a urinary tract infection, maybe pyelonephritis as well. So this is the diagnosis of our patient. So coming to the definition of sepsis, it is life-threatening organ dysfunction caused by dysregulated host response to an infection. So our patient had life-threatening organ dysfunction in terms of low blood pressure, and it was due to dysregulated host response. All the cytokines poured into circulation. It's not the bacteria causing the problem. It's not the bacteria causing the problem. It's the cytokine storm causing the problem, making your vessels vasodilated, mitochondrial dysfunction, lot of cellular effects, and it's due to infection. In this case, looks like the bacteria. Right. So how do you manage these patients? So we need to consider on 5 things: fluid, cultures, antibiotics, lactate, and vasopressors. I'll try to take you one by one. Coming to fluids, what type of fluid you need to use in this patient? Normal saline, plasmolite, hetastarch, 5% dextrose. Please answer. %66 believes it's normal saline, 25% believes it's plasmolite. Actually, plasmolite is a balanced, we call it balanced saline. And there are 3 of them, ringalactate, Hartmann's, and plasmolite. It is said that the balanced solutions are more physiologically related to our plasma. You need to use them. So that is another. In 2016, the guidance was either use normal saline or balanced crystalline. But now they have moved away from normal saline to balanced fluid. So if you have Hartmann's, ringalactate, please use them. Don't use normal saline because it can cause. There have been a lot of trials comparing these two. 30-day mortality of these people. If you have used balanced crystalloid, it has caused 9% relative risk reduction. Whereas normal saline, it has caused 1% relative increase. That is because of AKIs and hypochloremic acidosis and a lot of other complications. Right, coming to the next question. How much fluid do you give initially for this patient? 30 ml per kg, 50 ml per kg. Forty-six people have answered. Very good. It's 30 ml per kg, isn't it? So that is evidenced by a lot of observational studies from at the beginning from surviving sepsis campaign. So that's the amount of fluid you give. How do you give? How soon will you give this fluid? You give within 1 hour, you give it as fast bolus. How do you give? Or within 3 hours? %76 believes it's 1 hour. Only 24% believes it's 3 hours. Well, at the early period of surviving sepsis campaign, 2002, we used to give loads of fluids at the beginning. There was no limit, honestly. But now we are moving slightly away from that. We are coming to restrictive type of fluid usage in sepsis. It's actually you need to give them in 3 hours. You don't give it as a fast bolus. You give aliquots 10 ml per kg aliquots, and you see whether the patient is responsive for whatever the fluids you are giving, whether his blood pressure is coming up, whether his pulse rate is coming down, whether there's a response from the body. If you have a response, then you give another aliquot, something like that. So this is the correct answer. So within 3 hours you need to give. You need to assess fluid responsiveness. How do you do that? You can do it by clinical methods, by hemodynamic methods, and by laboratory methods. Under clinical methods, first thing would be patient will look more brighter. He would say, I'm feeling better now. His blood pressure would come up, his heart rate would come down a bit, his skin color will turn brighter, and capillary refill time will improve. So a lot of hemodynamic measures are there. You can do the passive leg raising test if you want, which is not practiced very well. And there are so many imaging based hemodynamic measures to assess cardiac output and all, and there are laboratory methods as well. Coming into focus, so please see this video. Can all of you see that? So what does this video show? Collapsed IVC, engorged IVC. Yeah, majority believes collapsed IVC, isn't it? So collapsed IVC is a feature of hypovolemia in the body, and you can make this information for your to guide your fluid therapy. Can you see this video as well? It's a echo actually, point of care echo. Is it hyperdynamic LV or poor LV? Yeah, that's hyperdynamic LV, isn't it? You saw the kissing sign, approximation of walls of LV together. So that's another feature to say patient is hypovolemic, and he can be given fluid. When do you start vasopressors in sepsis? Next question. When the patient is no longer fluid responsive and having MAP of less than 65, or at the beginning of resuscitation along with fluids. Yeah, that's the case. You don't start vasopressors at the beginning. You see whether the patient is fluid responsive. If not, if the MAP is less than 65, you need to start a vasopressor on these patients. So our patient, we have given the first 10 ml bolus Hartmann. Her blood pressure has risen up to 88, 64 and 46, and pulse rate has come down to 110. So was she fluid responsive? Yes. So we went on the second bolus, but after that the blood pressure remained same and pulse rate remains same. We thought she is not fluid responsive, so we had to start a vasopressor for this patient. What vasopressor you start as the first line? Adrenaline, noradrenaline, vasopressin, dobutamine. Please answer. Lot of answers for that question. Very good. Yeah, brilliant. It's noradrenaline, isn't it? So that has been the practice for a long time. Very good. We started it and we increased up to 0.5, but still the MAP is 60. What do you do now? Increase noradrenaline dose gradually up to 1 milligram, or add vasopressin. What do you do? Please answer. Very good. So yes, some good old days, we were increasing noradrenaline up to the level until patient can tolerate. That was the ceiling, 1 milligram, 1.2, 1.5 even we have gone. But now the new guidance is at the level of 0.5. You better switch on to, you better add vasopressin for these patients. So second line vasopressor is vasopressin. If there's a cardiac dysfunction, if you suspect, you can add dobutamine instead of vasopressin. How do you start giving vasopressors? Do you use a peripheral line or do you need a central line for these people? A lot of people believe that you need a central line. Is it? Well, what to get a central line, you would take a lot of time, isn't it? It needs certain expertise, you need a scanner, this and that. So by the time patient could deteriorate because of low blood pressure. Therefore, it's advisable to use a peripheral line for few hours until you get your blood pressure up and then change into a central line. So this can be done even in the medical ward, even any setup. You start with a peripheral line. Of course, it has to be proximal to the cubital antecubital fossa. That's for sure. And you get the blood pressure up and then go for a central line later on. That's the answer. Right. Only for short period time in a vein or proximal to the antecubital fossa. Coming into cultures, so we have started her noradrenaline and then vasopressin, and we were able to get her blood pressure up a bit around 95, 60, map more than 70, and we got a central line as well. Now we discuss about cultures. So cultures, we need to obtain blood cultures prior to antibiotics. That is a must, because sterilization of cultures can occur within minutes, and identification of pathogen, as Mudita said, is paramountly important in dealing with sepsis in long term. Coming into word about antibiotics, I'm pretty sure there will be a lot of talks about antibiotics. We need to give about broad spectrum antibiotics as soon as possible for a person whom you believe that patient is in shock, high risk of sepsis and in shock. That type of a person, you need to give antibiotics as soon as possible. You can start with empiric broad spectrum antibiotics for these patients. So there in Surviving Sepsis Campaign Guideline 2021, there's a guidance for using antibiotics. Some time ago, when we suspect sepsis, we used to start antibiotics then and there, immediate antibiotics. But it has changed now. If you need to categorize the risk of this clinical syndrome being sepsis. So if you think it's high risk, and if the patient in shock or sepsis, even non-shock, you need to give antibiotics within first hour, very quickly. But if it is intermediate risk, patient in shock, again you need to give antibiotics quite quickly. But in a non-shock state where you have intermediate risk, you can defer your antibiotics. You can get your CRP, full blood count, procalcitonin, whatever the evidence to support your diagnosis, and because it takes time, isn't it? And then start antibiotics. If the risk is low, you could defer giving antibiotics, because it has been shown a lot of people whom you have started antibiotics thinking sepsis on admission, they have turned out to be different clinical syndromes. Therefore, don't jump and start antibiotics on people whom you think, unless you think there's a high risk or the patient is in shock. Right. Administration of antibiotics is a responsibility of nurses. Yes or no? Please answer. %10 of people believes it's yes, but 90% believe it's no. Yeah, it's a team responsibility, isn't it? You are the in charge, so it's your responsibility, honestly, because antibiotics is a game changer. If you want to start, it's your responsibility, because writing up in the notes has been the old practice. You need to be there to see things done. A lot of things might have to be done to get these antibiotics within 1 hour into the patient's way in circulation. Therefore, It's not nurse's responsibility, it's your and the team responsibility. Please supervise, please stay with the patient, give the antibiotic, don't leave the patient before you give it. So, coming to guiding resuscitation, we can use lactate for sure, that has been in the practice. But now the new guideline advises us to even to use capillary refill time. It has been shown that it's a independent marker to assess organ perfusion. This patient has a metabolic acidosis pH 7.19. Will you give sodium bicarbonate for this patient? Yes or no? She had lactic acidosis, lactate was 4 and something. pH is severe acidosis, less than 7.2. 36% believes yes, one third. Majority believes no. The answer is no. You don't give bicarbonate in sepsis, lactic acidosis, unless patients have AKI. If the patient has renal failure, there's a chance for sodium bicarbonate, not otherwise, because sodium bicarbonate there's a lot of side effects, intracellular calcium metabolism, blah blah blah. A lot of problems are there. Only if there's a renal impairment. So during the initial hours, initial gestation, we did give fluid 20 ml per kg, cultures done, coamexiclav has been started, noradrenaline, vasopressin, both has to be added. We got a central line and departmental ultrasound showed pyelonephritis. So that medical management has been done and we were able to brief the patient and the family as well. That's another very important part in the guideline and it has to be in our practice. So explain this patient, give them the confidence that you are better cared under our care and give them hope, brief and explain things. That also has been done. So after the initial 3 hours, patient was feeling well, saturating well, blood pressure 170 on noradrenaline vasopressin, CRFT you can see 2 seconds, urine output has started, GCS fine, lactate has come down to 2, but she was on 2 iron drops. So we had to send this patient to HDU for the further care because sepsis can affect multi organs in later on as well. So patient has been sent to HDU. So the take home message, ladies and gentlemen, unstable physiology will lead to arrest and death. Our goal is stabilizing the physiology during initial hours and then address the pathology. In sepsis, 5 things you need to take care of: fluids, cultures, antibiotics, lactate, meaning the organ perfusion, and vasopressors. And always team efforts and good attitudes toward the patient will save our patients. So I would like to thank all of you for your patient listening and all my patients, KSM, Saman and other people, and Mudita, my dear friend. Thank you so much. You could keep this day for our annual conference. Come and join us in Colombo. Thank you so much.
Thank you, sir, for the interesting case-based discussion and for the enthusiastic audience participation. I would like to call upon Dr. Chandra Kapilawala, Consultant Pediatrician of National Hospital, Kandy, to present the certificate of appreciation to Dr. Ganaka Senara. Thank you, sir. On behalf of the KSM, I would like to remind you all that there are 2 files are passing around, one for filling the application forms for KSM membership and other one for collecting details to add you all to the WhatsApp KSM group. Please feel free to fill them as well. Thank you, ladies and gentlemen.
You can ask.
Yes.
Thank you very much for your exact presentation. Said the guiding of resuscitation done to the capillary refilling time, but in wait for the map to reduce until less than 65 to start, why not? Can't we go by the capillary refilling? That is the earliest.
Map to
Yeah.
Can I have mine? I'll go there. So, Chandana, your question is, I didn't get the question correctly.
We use, according to the responses, we start iron torch, then the max is less than 65.
Yes.
But the idea for resuscitation is that a capillary refill type.
We are the map is a marker we measure, but no point in having map if you don't have a peripheral perfusion. So map is a central something, isn't it? We measure it here. It's very good if you could do it put a arterial line and do it, but at the same we need to keep it above 65. At the same time we need to know whether our peripheral organs are perfused or not, having this map. So that is why you use lactate is used in that regard. Lactase is produced because of anaerobic metabolism in the organs, and at the same level you can use the capillary refill time, because they have compared these two parameters and try to see the effect, try to predict the mortality as well, as I can remember in some trials. So they say you can use lactate as well. That is what we use generally. We get a lactate level after 1 hour, 2 hour to see whether whatever we are doing is correct. But at the same time, they say you can use capillary refill time also. That might give the same amount of information. Have I answered the question? But map is a different thing. You need to definitely keep it above 65. No question about it. Thank you so much.
Thank you, ladies and gentlemen. Now we have a talk centered on critically ill patient with sepsis. It will be delivered by Dr. Dushani Hettiarachchi and consultant intensivist at National Hospital, Kandy. Dear madam, the floor is yours.
Okay, now you have to have the mic.
Good morning, everybody. I think that Dr. Senarath has already touched on several aspects that I'm also going to talk about. It's going to be easy. My main focus during this presentation will be on actually fluid management, because in my opinion that is the aspect of managing the critically ill septic patient that can make a huge impact by just simple interventions. So I think it's very important to focus more on fluid management. So going into a case scenario again, this is a 58-year-old man with a past history of diabetes, hypertension, ischemic heart disease with a documented latest ejection fraction saying 45%, coming to ETU with a 5-day history of fever, myalgia, productive cough, and worsening of the symptoms over last 3 days, mainly worsening shortness of breath. So on admission to ETU, patient is a bit confused, febrile, blood pressure is low, 87/56, tachycardic at 128, got cold peripheries, saturating around only 88% with maximum oxygen through the non-rebreathing mask, and tachypneic at 38 breaths per minute. So the working diagnosis here is severe community acquired pneumonia. So the APG done at the ETU says the pH is maintained within the normal range 7.4, carbon dioxide being washed off 19, so obviously because the patient is tachypneic, and oxygenation is marginal, it's only 66 while on 15 liters, which is around 80% of inspired oxygen. Lactate is high 3.6, bicarbonate down to 12 with a base deficit of 10. So this is the blood gas analysis done at the ETU. So when would you consider sepsis in a patient coming with an infection? So by definition, this is life-threatening organ dysfunction caused by dysregulated host response to infection. So the key feature is presence of organ dysfunction in the setting of infection. So in this patient, there's obvious organ dysfunction manifested by confusion, low blood pressure, and desaturation. So the patient with sepsis is a subcategory in the patients coming with infection, and those with septic shock by definition having a systolic blood pressure below 90 and having high lactate above 2 despite adequate volume resuscitation. So you can see in those with septic shock the mortality is significantly high, reaching more than 40%. So the screening tools Dr. Senathan has discussed, as we discussed in the previous era, we paid more attention to Q SOFA, which in the latest guideline is being de-emphasized because it's less sensitive and specific in diagnosing, detecting sepsis. So search criteria are better. We said SOFA score is a better score, but it's difficult to be used in the ETU setup or ward setup because on admission we can't assess SOFA score because it needs some investigation findings which won't be available on patient to be assessed on admission. So it's good for assessment after like 48 hours. And I wanted to mention about the early warning scores because I feel in our setup, especially in the ward setup, if we can utilize the early warning scores, at least for the patients coming with infection who are doing not well, who need HDU care in the ward setup, if you can utilize this score, it can help detecting the deteriorating patient early. I think in our setup also in Kandy, in some surgical units, they are using the early warning score with some good results. So what I want to tell is that there's no single gold standard to diagnose sepsis. It's the clinical judgment mainly. In any patient coming with an infection who has additional organ dysfunction, please think whether this is sepsis. The 1 hour bundle, I think emphasized in the previous lecture as well. We'll discuss when we go through ICU admission. So when you decide a patient with sepsis needs ICU admission, it's mainly for organ support as for any ICU patient. So timely application of critical care interventions is vital when admission to ICU is indicated. So early admission to ICU when it is indicated, like without delaying, can help in minimizing complications. Like if the patient comes to ICU earlier, most of the time we can save the patient just with fluids. That's why I wanted to emphasize not having to put a central line in, not having to go for ventilator support, not having to start renal replacement, just by fluid management, because the patient gets close monitoring in the ICU. So with simple interventions, we might be able to rescue the patient and send back to ward if the patient comes to ICU early. It is said that ICU mortality is increased by 1.5% for each hour delay at ETU or the ward setup. Getting an ICU bed is a different issue. So that is why the last point, regular assessment, evaluation and appropriate treatment should not be delayed independent of patient location. So whenever possible, until you get an ICU bed sorted, appropriate interventions guided by the available guidelines should be implemented. Fluid resuscitation is the 30 ml per kg crystalloid within the first 3 hours. So this is given as a fixed volume, 30 ml per kg based on observational evidence. It says that this particular volume, the 30 ml per kg of crystalloid within 3 hours. Failure to receive 30 ml per kg within the 3 hours is associated with increased hospital mortality, delayed resolution of hypotension, and increased length of ICU stay irrespective of comorbidities, including end-stage renal failure and heart failure. This is the point that I wanted to emphasize on, because most of the time we see when the patient is coming with heart failure plus sepsis, we tend to avoid giving fluids. So what we see commonly is we start on furosemide before starting on adequate fluids, because patients coming with sepsis are always with a deficit, so they definitely need initial fluid resuscitation, but we have to be cautious. That's why the patients already having end organ dysfunction better be managed in an ICU setup. So coming back to our patient, he has got a past history of ischemic heart disease with an ejection fraction of 45%. So on arrival to ICU, the patient has already had around 1 liter in the ETU. GCS still 14, bit confused. He's saturating fine on 90%, but still needs 15 liters to the non-rebreathing mask. Still tachypneic. Patient has got a urinary catheter in now, but apparently there's no urine output, which is quite alarming for the ICU team. Blood pressure is still low, it's below 90, and still tachycardia, but bit better than what he was, probably with the fluid resuscitation in the ETU. So initial management in the ICU setup, monitoring of the vitals. Ideally, all the critically ill patients in the ICU should have an art line in, but in our setup we don't use in all patients because of the resource limitation, but in the ideal setup they should have an art line. So non-invasive blood pressure at least 5 to 10 minute intervals, continuous ECG, saturation, input output, and temperature. Those are the key vital parameters that we should monitor closely. Patient is changed to high flow nasal oxygen. Start at around 40 liters, 40%, to be titrated to target levels of saturation. So until we assess the patient has already had 1 liter in the ETU. So beyond this point, as Dr. Senarathan explained, after 10 ml per kg, that is like will be around 750 ml for an adult man. So after completing 1 liter, definitely you have to go for a reassessment. See whether the patient is fluid responsive. See whether we can give the rest of the bolus safely in this man with an ejection fraction of just 45%. We start our fluid resuscitation, continuation of the fluid resuscitation with a small bolus of 250 ml of finger lactate. We repeat the blood gas on arrival to ICU. After getting 1 liter of fluid, the patient is still having low blood pressure, and given the history of ischemic heart disease with low ejection fraction and absent urine output, being a hypertensive, we think of doing a central line at this point and send all the basic bloods if not have been sent at the ETU, including the cultures. And never forget to talk to the patient, orient the patient, reassure the patient, and whenever you get a chance, talk to the family, get an extended history. That is very important. Even in the ICU setup, I always pay attention to talking to the family members. We have to update them plus get an extended history. So how are we going to spread this 30 ml per kg dose over 3 hours? Can we give it safely in anybody? As I said earlier, there is always a fluid deficit. So you don't have to worry about starting the initial fluid bolus. Most commonly, in any patient coming with sepsis and septic shock, you can safely give up to 500 without any issue as a bolus, whatever the baseline ejection fraction or renal function is. But after this initial 10 ml per kg bolus, we have to be cautious and assess for the fluid responsiveness. As we discussed, there are static parameters and dynamic parameters. You all know that we pay attention to dynamic parameters. We don't go by blood pressure, heart rate, central venous pressure, which are static parameters. So what are the dynamic parameters of assessing fluid responsiveness? Passive leg raise is the simplest available dynamic parameter, I would say, which can be easily applied in the ICU setup. It's difficult in the ward setup or ETU, but in ICU, we generally can do this. It gives a volume of around 500-750 ml in an adult, which most importantly is a reversible bolus. So that is why it is important. So as you can see in this picture, first the patient should be lying flat with head end elevated, and then you get the pulse pressure and heart rate readings, and then you elevate the legs and keep legs elevated for up to like 60 to 90 seconds. Then get the pulse pressure reading and the heart rate. For this to be done, ideally the patient should have an outline in, but generally, as I said earlier, we don't have outlines in most of our patients, but with the non-invasive blood pressure measurements, we still practice this. So more than 15% rise in the pulse pressure indicates volume responsiveness. Systolic pressure, pulse pressure variation and stroke volume variation, I think you have heard about these terms. During spontaneous breathing, in a spontaneous breathing person, blood pressure decreases during inspiration and increases during expiration. But in mechanically ventilated patients who have positive pressure, positive intrathoracic pressure, this is reversed. So pulse pressure variation is the difference between the maximum and minimum pulse pressure divided by the mean pulse pressure. In the diagram, you can see the maximum pulse pressure and the minimum pulse pressure during a breathing cycle or during a given time interval. So the difference divided by the mean pulse pressure, that is the pulse pressure variation. So a value above 10% is suggestive of fluid responsiveness. This again ideally needs an outline in, but even without an outline in our setup, we can practice this. Stroke volume variation, the same principle again. Maximum stroke volume divided by maximum stroke volume minus minimum stroke volume divided by the mean. For stroke volume variation, we should have cardiac output monitoring in place, which we don't have freely. Still, we can go by pulse pressure variation, which is considered to be the poorer cousin of the stroke volume variation. But in our setup, we still can use pulse pressure variation. IVC collapsibility, is it a dynamic or a static parameter? IVC collapsibility can be used as a static parameter as well. Because when you check for IVC collapsibility, if it is collapsing, you can give a bolus and you can reassess. Then you are using it as a dynamic parameter. That is the usefulness of IVC collapsibility. IVC collapsibility alone in a single measurement is not considered a good parameter because, as I mentioned, then it is not a dynamic parameter. You can assess the IVC, give a fluid bolus if you can see the patient is responsive, and then reassess. If it is still collapsing, then you can repeat another bolus and then reassess. That's how you use IVC collapsibility as a dynamic parameter of fluid responsiveness, which is very helpful because it is non-invasive and it only needs the ultrasound machine and some expertise to find the IVC. Bedside echo. This also needs some expertise, but when you practice, you don't need to know the hi-fi stuff. I'm not going into details of the complicated stuff of FICE, but when you keep the probe, this is the short axis view, hyperdynamic and small left ventricle. That is what we commonly know as the kissing ventricles. The kissing ventricle sign is a good indicator of fluid responsiveness. And as in this picture, this dilated right ventricle generally is a very specific sign showing that the patient is no longer fluid responsive. When you start resuscitation, if you put the probe on the chest and see, you will see a collapsing right ventricle. Then you can give a bolus. And when you reassess, if you see a dilated artery, you better rethink before you go for the next bolus. But you have to keep in mind, dilated artery is not specific for fluid status. Because as you all know, if you see a dilated artery on the first assessment, you have to think about other pathologies like pulmonary embolism. At the same time, you can put the probe on the chest and see whether the lungs are wet or not. After giving several boluses, if the patient's oxygen requirement goes up, like say if the patient was initially on nasal prongs 2 liters oxygen and you are continuing with fluid resuscitation guided by all the parameters, and then you find that patient is a bit more tachypneic and requiring more and more oxygen, and you find some fine trickles on auscultation over the lung bases, then you better put the probe on the chest and see whether you can see these B lines. More than 3 B lines per area is considered to be pathological. Then you have to rethink about continuing fluid resuscitation. Because I know most of the medical registrars are very competent in using the ultrasound scan probe in assessing the IVC collapsibility and cardiac function also, but just put the probe on the chest as well, the cardiac probe or the same curvilinear probe, just put it on the chest and see whether you can see B lines. So the other clinical parameters are also very important. The capillary refill time, the peripheral coldness, skin mottling, altered ventilation, excess thirst, tachycardia, oliguria, hypotension, and lactate levels. Don't disregard, don't forget to examine the patient. That is the message. Before putting the ultrasound probe on the patient, please talk to the patient, examine the patient, touch the peripheries. You can gather a lot of investigation, a lot of information. So, what I want to emphasize in assessing fluid responsiveness, it's not only one, it's not a single parameter that we are going to assess, not only the IVC collapsibility, not only the pulse pressure variation. It's the combined effect of all these parameters that should lead to a clinical judgment of the volume status. So the type of the fluid, as explained previously also, in our setup, we are using Ringer's lactate commonly, which is the balanced crystalloid that is available for us. Plasmalite is ideal, but it's not freely available. What I want to emphasize is try to avoid large volume resuscitation with 0.9% sodium chloride, which can have other detrimental effects, mainly hyperchloremic acidosis. In our ICU setup also, we are still experiencing, we continue giving normal saline and patient ends up in like 48 to 72 hours time getting high sodium. Then we have to address another additional issue on top of the underlying pathology. So please change to Ringer's lactate from normal saline, which used to be our practice for a long time. Use of albumin in ICU setup we commonly use to rescue as a rescue method, which means after giving like 2 liters of fluids, if we still feel that patient is fluid responsive and still blood pressure is marginally low, then before starting the next bottle of Ringer's lactate, we generally use a bolus of albumin. We can use our 20% albumin vial into 1 pint of our crystalloid and make it 5% and infuse. So after resuscitating with large volumes of crystalloids, you can go for albumin, but its use is not very highlighted because of the because it has not shown any mortality benefit and the effect and the problems with cost effectiveness. The target map is 65. In earlier guidelines, it was like something above 65 millimeters of mercury, but now what they say is target map is 65. But in patients with chronic hypertension, you have to be vigilant and maintain a target map above this. If the patient has a history of hypertension in the ICU setup, we generally go for a target map around 70 to 80, at least 80, the minimum of 80. The first choice of vasoactive drug is noradrenaline, irrespective of the type of shock. Even if it is a cardiogenic shock, the first choice is NORAD. If starting vasopressors is getting delayed due to absence of central line, you can go for some peripheral vasopressors like metramidol, which I think is available in the ward setup as well. Even in ICU setup, if we think on assessment that the patient has had enough fluids and there's no more room to give more fluids, and if the patient is having low blood pressure, no urine output, then we go for some peripheral vasopressors like metramidol or ephedrine until we set up the central line, because we don't allow the patient to have low map and get the kidneys at risk. When a patient with septic shock comes to ICU, one of the most important concerns is about preserving the renal function, because if we lose the renal function, sometimes the patient might end up with lifelong dependence for dialysis, which we need to prevent. Peripheral noradrenaline can be used as explained previously also by Dr. Senaratna. In the ward setup, if you can't have access, a good venous access, ideally it should be above the antecubital fossa, but if you don't have, you can still use for very short periods even a distal cannula, but maybe with a double dilution. So in a 500 ml of saline, because the harm that can cause from not starting a vasopressor on time can be very damaging, can be a lifelong problem for the patient. So after resuscitation in the ICU, GCS has improved, still on high flow, less tachypnic, blood pressure improved with a reasonable MAP, now on NOR at 0.5 miles, still getting ringer lactate 100 mL per hour, plus liberal oral. Echo done, says confirms the previous ejection fraction as 45%. The concerning thing is now the urine output is minimum. So there has been no urine output for initial 2 hours. He has started passing some, but inadequate. So intake up to now has been like about 3 liters, but the urine output has been only about 60 mL. And creatinine from the baseline of 88 has risen to 200. So now the patient is in AKI. The blood gas, the repeated one says the pH is within the normal range, carbon dioxide 21 and oxygenation improved, lactate down to 2.5, bicarbonate still low 10, and base deficit actually is a bit worsened. So on the initial blood gas, when the patient is coming with a high lactate plus a significant base deficit, we generally continue with fluid resuscitation irrespective of the pH value. But if the patient is a known patient with CKD, or if the pH value is below 7.15, then we consider bicarbonate. At this point, would you consider bicarbonate? This is not a patient with CKD. pH is 7.4. Would you consider bicarbonate? That is the question. The guidelines do not recommend IV bicarbonate when pH is more than 7.15. What about going for renal replacement therapy? The patient now has been like for 6 hours oliguric, creatinine more than double the baseline. So he's definitely in AKI. Are there any indications to start renal replacement therapy in this patient? By the urine output parameters, yes. For more than 6 hours, he has been not passing enough urine, now with significant positive balances. When would you start renal replacement therapy? Timing of initiation of renal replacement therapy has no effect on mortality and renal recovery. There's a weak recommendation against the use of renal replacement therapy in patients with sepsis and AKI for increases in creatinine or oliguria alone and without other absolute indications for dialysis, like uremic complications, refractory acidemia, refractory fluid overload, or hyperkalemia. Overall, the balance of effects favored delayed rather than early initiation of renal replacement therapy. There's no recommendation on modality of renal replacement therapy or a difference between continuous modality, that is CRRT, or intermittent dialysis. So what about our patients? Would you start him on dialysis? Now the patient is on NOR at 0.5 miles and oligoanuric. How would you continue with fluid resuscitation for the patient who is not passing any urine and with an ejection fraction of 45, which again is concerning? So in this scenario, the blood gas parameters are also not very favorable. You can see that pH, if you go by the pH alone, it's fine. It has always been fine. But the patient still is pushing carbon dioxide and his base deficit is worsened actually. That indicates ongoing and worsening renal impairment despite our fluid resuscitation and maintenance of an adequate MAP. As the evidence say, there's no recommendation in early initiation of renal replacement therapy for indications like oliguria alone. So we can go for watchful waiting for some more time. In the meantime, what can you consider? What else can you consider? In our patient, actually, we go for IV bicarbonate and try some furosemide, which are not in the guidelines. But in our setup, we commonly practice IV bicarbonate in patients who don't have the recommended pH level. Even in this patient with a pH of 7.4, but still in renal impairment and low bicarbonate, irrespective of adequate fluid resuscitation, we start on bicarbonate. And in the meantime, we try furosemide bolus. Furosemide may not be indicated. The indication for furosemide is, in this scenario, is only evidence fluid overload. But in this patient, we don't see any fluid overload. Then why are we giving furosemide? Is it rational? In some cases, we know that in patients with ongoing renal impairment, when the kidneys have started to shut down, when you give a bolus of furosemide, that acts as a kick. Sometimes, commonly, we see they start working. So after giving a bolus like maybe 20 milligram, just a stat dose. Then the next hour, urine output will be 50, 60, and then next hour it will be 100. Then starts working. So that we commonly experience, and we practice, though not in guidelines. So that's what I wanted to say. In our setup, in the ideal setup with this blood gas, after like more than 6 hours in the ICU, if this blood gas occurs in the ideal setup, they would go for continuous renal replacement therapy, which is freely available in the ideal setup. But in our setup, we don't have renal replacement therapy, which is very freely available. So we try to minimize using dialysis in any form in the ICU setup. We try our best to get the kidneys function. So that's why we are very concerned about maintaining adequate fluid status, maintaining the ideal MAP for the individual patient, and try with other measures to delay the patient going on renal replacement therapy. So in this particular patient, we started bicarbonate, the isotonic thing we can use, with a small dose, which will help resolution of this metabolic acidosis, and with the furosemide kick, the patient will start passing urine. If that is not going to happen, then only you have to consider going on renal replacement. What I wanted to emphasize is that you have to take all other measures that you can do as interventions to prevent patient going on dialysis, especially in our setup, which is a resource poor setup. So always reassess and go by all the parameters. So at the end, you get a nice blood gas. The base deficit is improved, lactates down to 1.2, pH remains normal. Some other aspects, immunoglobulins, there's no good quality evidence for mortality benefit, not cost effective, so not routinely recommended. Insulin, the target blood sugar values are around 140 to 180 in the ICU critical ill patient. We maintain by insulin infusion. Steroids, IV hydrocortisone, we generally start at 50 milligrams 6 hourly when the inotrope support is required above 0.25 mics per kg per minute of NORAD. So that is the starting point for steroids after about 4 hours of starting that dose of vasopressor support. So what I want to emphasize is detecting septic patient who's deteriorating early and sending to ICU without delay, and until you sort the ICU bed, attending the vital parameters, closely monitoring in the HDU setup at least in the ward to prevent further complications. Continue free resuscitation with clinical judgment. The guidelines are only a guide. Always you have to individualize for the patient. Try to minimize renal impairment. You have to take all the necessary measures to save the kidneys. It is very important, very, very important in our setup, in this poor setup. And timely transfer to ICU. So that's it. Thank you.
Thank you very much, madam, for educating us on how to manage a critically ill patient with sepsis. Now I would like to invite Dr. Kirti Kulratne, Senior Consultant Physician, to present the Certificate of Appreciation to Dr. Dushani Hettiaraj. Thank you, sir. The session is now open for any questions to be asked from the speakers. Thank you, ladies and gentlemen. We shall now have a brief tea break for 15 minutes before we resume the next session. The tea will be served for participants in the lecture hall and for the consultants in the conference room. Thank you.
ඒ ටොපික් එකෙම තියෙනවා කියලා කිව්වා. අපි මේ questions බලනවා අහලා
ඒක තමයි හොඳයි.
Can't hear ඉස්සලා තියෙන්නේ. Please unmute if muted. Slides not changing online. Students cannot see the slides. Questions නෑ. අර මුල තිබිච්ච problems ටික විතරයි. ඒක ගන්න කරලා දාන්න. हाँ අද රෙකෝඩ් කරේ නැත්නම් රෙකෝඩ් කරලානේ එහෙනම් මම ඉන්නේ අහලා තිබා කට්ටිය part 5.
Right. Okay.
Then done. Oh, අද කොල අද මේකේ ඒගොල්ලන්ගේ මේ එක්සෑම්ස් ගියා මේක ලංකාවේ ජැනුවරිය. හරි මේ මට ලෙක්චර් එකක් ටක් ගාලා සෙට් කරගත්තා. සෙන් එක අයින් කරන්නත් පුළුවන් දැන්. හරි වාගේ කරා. ස්ලයිස් බලන්න දෙයක් නෑ. නෑ. ඒක පළවෙනි කීපෙ ගියා. අනේ කියමු.
මම මෙහෙම යන්න දෙනවා. හරි සර්. මගේ මේක මකන්න මේ සකින් අයින් වුණේ සර්. ඔව් ඒකෙන් අයින් වුණා. ඒකත් මගේ වෙන එකට එන එක කරේ කවුන්ට් එක. ඔව්. මේකෙන් සයින් අවුට් කරන හරිනේ සර්. එතන එක මිනිමයිස් කරන්න. යා ඒක හරි. ඒකටත් බලපානවා. මේ Hari Padma, happy. Thank you so much for all the help given. Yeah, Nishan.
කටිනකට දාමු මොකද මේ මොකද සර්ගේ නේ මඩගේ ප්‍රසන්ටේෂන් එක දාලා චෙක් කරා ඊට පොඩ්ඩක් ප්ලේ කරලා
ඒකට කටි ආවම දැන් මොනවද වෙන්නේ
දැන් කට්ටිය ඇවිල්ලා වාඩිලා පටන් ගන්න කලින්ද නාටක කීයක තරකක්ද
මගේ විනාඩිය
රිපීට් වෙන දාමු
රිපීට් වෙන විනාඩි 5ක දාන්න කිව්වා 1 මිනිත් වෙන කියන්නේ රිපීට් එක
check one ඊට sound එනවා
The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well. The best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life.
Ladies and gentlemen, we shall now resume the fourth session for the day, which will be presented by Dr. C.M.D. Hera, who is a consultant pediatric intensivist at MICU Sirimavu Bandaranayake Specialized Children's Hospital, Peradeniya. The title will be Septic Shock Management in Pediatrics. So I warmly invite you to the stage.
Good morning. I am Dr. Madhushan Hera, consultant pediatric intensivist in Children's Hospital, Peradeniya. So my topic today is the pediatric septic shock. So as you all know, the sepsis it defines as a life-threatening organ dysfunction caused by the dysregulated host response to the infection. And the septic shock is the part of the sepsis which associated with the circulatory and metabolic disturbances and which has the higher risk of mortality. So why we are worried about it? Because it still remains significant cause of morbidity as well as mortality, and nearly 30% of pediatric sepsis patients will progress into septic shock, and mortality remains comparatively high in pediatrics, 20 to 30%. In some countries it is 50%. When the patient admit to PICU or ward, most of them are having multi-organ dysfunction on admission. It's nearly 67%. Is it easy to identify pediatric septic shock? The answer is no. Why? There is no single gold standard diagnostic test for the pediatric septic shock diagnosis. And we are making the diagnosis with combination of clinical signs as well as the hemodynamic parameters. We combine both together and make the diagnosis. But the problem is in the pediatrics, the vital signs, the clinical signs varies with age as well as the laboratory test. They are also varies. The creatinine, the WBC counts all are varies. So it takes some time to identify the abnormal vital signs in the pediatrics because there is no single cutoff value as in adults. And also there is some problems. As you all know, the children are crying. So sometimes it may also cause increased heart rate, increased respiratory rate, sometimes in the blood pressure as well. So sometimes we can miss the diagnosis as well. So these are the problems in the pediatric septic shock. Problem is recognition. Then we look at the pathophysiology septic shock. This is the most important thing in the septic shock. So as you know, when the bacteria or bacteria endotoxin enters into our bloodstream, what happens? Our WBC come to fight against it. Then it releases the massive cytokines. Actually, it is a cytokine storm. It is not purely due to bacteremia. Then these cytokines act on various organs in our body. It may affect the brain, cause cerebral dysfunction. It may affect the kidney, may cause acute kidney injury, or it may affect especially the vascular system, may cause the shock. There are three main pathophysiological phenomenon in the pediatric septic shock. The first one is increased vascular permeability. The second one is the systemic vasodilatation. The third one is the impaired cardiac contractility. These are the main three things that occur in the septic shock. The septic shock is not an isolated shock. It combines the hypovolemic shock, the distributive shock, as well as the cardiogenic shock. If the cytokines act mainly on the vessels, what happens? It causes massive fluid leakage and causing hypovolemia. So it resembles the septic shock. The part resembles the hypovolemic shock. And then if the cytokines cause in vasodilatation, what happens? It behaves as an anaphylactic shock. So distributive shock. And if the cytokine storm mainly affects on the heart, what happens? It suppresses the cardiac contractility. So there are three. That's why I highlight these three things. So how do we manage these patients? The septic shock. So the hypovolemia, what is the management? Fluids. The distributive shock, the anaphylactic shock, what is the management? Vasopressors. No? The cardiogenic shock, what is the management? The inotropes. So in the septic shock, you have to have three management options: fluids, vasopressors, and inotropes. So let's see how it differs from the adult septic shock. As you know, the hypotension is universal in the adults, but the pediatric, it is a late sign. That is very much important. The adults usually present with a warm shock, especially some vasodilatory type shock. But the pediatrics, most of them admitted with the cold clammy extremities. They are in the cold shock. The incidence of adrenal insufficiency is relatively high in the children. Therefore, we have to always check the blood sugar when the resuscitation. They are more prone to get hypoglycemia. The hypotension in a septic child. What's the problem? As I discussed, the hypotension is a late sign of septic shock. So it is called as a pre-arrest stage, not like adults. So hypotension in children is a pre-arrest stage. Why? You know, the map of blood pressure equals cardiac output into total peripheral resistance. And the cardiac output equals heart rate into stroke volume. So children has maximum compensatory mechanism to normalize the blood pressure, the map. They can increase the heart rate and total peripheral resistance to great extent to compensate the map, the blood pressure. That's why they have the relatively stable blood pressure in the early shock. So the important thing I have to highlight is, do not wait for hypotension to diagnose septic shock. You should act early. If the patient is having unexplained tachycardia, even without shock, you have to think of, or you have to get the tentative diagnosis of septic shock. So how they will die, the septic shock child, because of the multi-organ dysfunction. So as an intensivist, my job is to survive the patient. So the goal of the resuscitation is you have to maintain adequate organ perfusion. Then the multi-organ dysfunction delays. Then we have adequate time to manage. So if you are able to maintain the adequate organ perfusion, then all the vital parameters will be normalized. The urine output will be normalized. The capillary refilling time, mental state, all are normalized. The lactate levels coming back to normal. But if you are unable to maintain the organ perfusion, if you assume the renal perfusion, then child will end up with acute kidney injury. If the child, if you are unable to maintain the brain perfusion, child will develop drowsiness and encephalopathy. Like that, the main goal of the resuscitation is to maintain adequate organ perfusion. Then look at the principles of management. As you know, the early recognition, the fluid resuscitation, the regular hemodynamic monitoring, the appropriate inotropes, antibiotic therapy, and supportive therapy for organ dysfunction. These are the principles of management. So, early recognition. This is the very much important pediatrics. Why? If you miss the diagnosis, then patient will be dead. Okay. So for that you have to develop a screening tool in your wards or in the institution protocols. You have developed to identify early sepsis. It is called systematic screening tool. So if you assume the patient comes with a history of malignancy, acute lymphoblastic leukemia to the ward, and while in the ward child developed fever, then according to the systemic screening tool, if the patient is having coexisting one of these thrombocytopenia, or if the patient develops altered sensorium with the acidosis, then you can make a diagnosis, the tentative diagnosis sepsis. Then you should start a treatment as early as possible. For that, you have to have a unit guidelines or protocols to identify early sepsis. It depends on the setup. So there are two algorithms that are using in the pediatric septic shock management. The one is the Academic Critical Care of Medicine 2017 guideline. The other one is the Surviving Sepsis Campaign Guidelines 2020. Actually, I am using both to manage the patient, but today I am going to discuss about the Surviving Sepsis Campaign 2020 guideline. So let's look at the stages of septic shock and the management, the main management. When the child present with the shock, first you have to do the fluid resuscitation, because as I explained, there is a severe increased capillary permeability causes massive loss of intravascular volume and causing less intravascular volume. So first you have to do the initial fluid resuscitation. Then if the patient remains hypotensive even with the maximum fluid boluses, then it is called as the fluid refractory shock. Then it's the time for starting the vasopressors. The vasopressors are adrenaline and noradrenaline. I will discuss it later. Then you have to titrate the adrenaline, noradrenaline depending on the organ perfusion targets to maximum. Then even with the vasopressors and fluids, if the patients can't maintain the blood pressure, or if the patient remains hypotensive, then it is called the catecholamine resistant shock. Then you have to add the vasopressin or either inodilators to make the patient to make the blood pressure up. But even with these measures, if the patient fails, then we are calling it as a persistent catecholamine resistant shock. Then you have to think again, is the diagnosis correct? Because sometimes we miss the other diagnosis. Then we should think about the alternative diagnosis. I will discuss it later. Then if your fluids, the vasopressors, the inodilators all are failed, then it is called the refractory shock. Then the treatment is the ECMO. In the Surviving Sepsis Campaign guideline, they recommended to do the 6 things in the first hour of resuscitation. First, the IV access. If you fail IV access, then you will go for the intraosseous access, and the blood cultures, broad spectrum antibiotics. Then you have to do lactate levels if possible, and the fluid resuscitation. The fluid resuscitation mainly takes part in the first hour. Don't give fluids for hours. Okay, fluid resuscitation mainly in the first hour. Then within 1 hour, if the patient is not improved with your fluids, then you have to at the end of the first hour, you have to start off adrenaline. Don't wait for hours to start adrenaline. Okay, if the patient is not improving in the first hour, then you have to start the vasoactive drugs to in the resuscitation. So let's talk about the fluid therapy, the initial resuscitation. Okay, fluid is the cornerstone in the management in the septic shock in the children, because they are having hypovolemia because of the cytokines act on the vessels, causing massive fluid leakage. In literature, they found the aggressive fluid therapy in pediatrics having remarkable reduced mortality. The fluid calculation done for which body weight? The actual body weight or ideal body weight? It should be done for the ideal body weight. Okay. Then we'll see what is the physiology behind the fluid boluses. So I think that you can remember the Frank Starling curve in the physiology days. If you think this is a heart, if you give more fluid, if the heart is normal, it pumps more blood, more stroke volume. If you give more blood as a bolus, it is a preload to heart, it pumps more blood to the as a stroke volume. The stroke volume is necessary to maintain organ perfusion. So when the patient comes, we don't know where is the patient. So the x-axis is the preload or the fluid boluses, and the y-axis is the stroke volume. We don't know where the patient stands. The patient anywhere is anywhere in this line. Okay, if the patient is in between the 0 to A, then if you give fluid bolus, patient improves. But if the patient is in the position B, what happens? If you give fluid bolus, patient push on to the fluid overload state, then patient dying of heart failure. Okay, that's why the fluid boluses, and after each fluid boluses you have to re-assist the children is very much important in pediatrics, because you are giving lot of fluids to pediatrics. So every fluid bolus you have to re-assist the child, otherwise the fluid overload, heart failure will develop. So how do we assess the fluid status? As the other speakers told, after fluid bolus you have to clinically recheck the features of fluid overload or heart failure. You have to actively look for the basal crepitations, any gallop rhythm, any hepatomegaly, or if the patients need any further oxygen requirement, or if you have the facilities, the hi-fi stuff, the echo or the ultrasound, then you can assess the fluid status after fluid boluses. That's how you should do the fluid boluses. Then the fluid is a drug in the ICU, even in the resuscitation. Why? If you prescribe an antibiotic, then you have to select what antibiotic you should select. If you assume the meningitis, you select the ceftriaxone. Then you need to prescribe the dose, either 80 milligram per kg, and the duration, and the dose once daily, the duration. Like that, if you prescribe the antibiotics, you adhere to these four Ds. But you don't adhere to these 4 Ds. But in the pediatric septic shock management, we have to adhere to these 4 Ds. If you do the resuscitation with fluid, first you have to select the correct drug, which means correct fluid. It may be normal saline, it may be Ringer's lactate. Then you have to select the correct dose, which means either 10 ml per kg bolus or 20 ml per kg bolus. Then you have to give over either 20 minutes or 1 hour. All things you have to document and tell to the nursing officer while resuscitation. Don't tell normal saline like that. Okay. And the de-escalation. What is the de-escalation means? Once the patient is improving with the fluid boluses, once the patient stabilizes hemodynamically, then you have to stop the fluids. Otherwise, patient will push on to the fluid overload state. So always remember these 4 Ds when you're prescribing fluids in the children. What are the recommendations in surviving sepsis campaign guidelines? The recommendation in ICU, you can go up to maximum 60 ml per kg fluid boluses within 1 hour. It is important within 1 hour. Okay. If the ICU is not available, if the patient is in shock, then you can go up to maximum 40 ml per kg in first hour. If the patient is in not shock, there is no need of any boluses. You can give either maintenance or maintenance plus 5% if it is like that. There is no recommendation of any fluid boluses if the patient is not having shock. Now let's talk about the fluid overload as well, because if you give more fluids without reassessing, child might go into the fluid overload. What happens if you give more fluid without reassessing? Then these fluid go into our organs, causing intestinal edema, visceral organ swelling. Most of our organs in the abdomen. What happens when the fluids inside the abdomen? It causes increased intra-abdominal hypertension. Then the result is then child is having low urine output. Then the urine output is a mark of the circulation. Then what will you do? If the low urine output, again you give the fluid boluses. So it is going in the vicious cycle. Okay, that's why I again highlight, if you give fluid bolus, you have to reassess, because hypovolemia as well as hypervolemia is detrimental in the pediatrics. In literature, they say the cumulative balance is more than 10%. It has high risk of mortality. Fluid is needed, but for some amount. Then type of fluid in the pediatrics. What is commonly used in resuscitation? The normal saline, 0.9 normal saline. Why? Because of the availability and the cost, low cost. But the recommendation is the balanced solution. The normal saline is not balanced solution. It has high chloride concentration. So the recommendation is the Ringer's lactate or the plasmalide. Why? They found in literature, if you give the normal saline boluses, the pediatric maximum 60 ml per kg bolus, so it can cause hypochloremic acidosis. Then it can lead to acute kidney injury and increased mortality as well with the normal saline. Always use Ringer's lactate if the patient develops septic shock. The guidelines recommend against use of that 5% albumin and the gelatin or gelfusin. This is the literature. They say clearly in pediatric you use the balanced solution because it improves the survival and decrease the prevalence of kidney injury, and the shorter duration of vasoactive infusion needed in the if you give the balanced solution. Hemodynamic monitoring, it is essential. Why? The septic shock in pediatric, time it differs. Initially it may be cold shock, in few minutes time it's a warm shock, it differs. The continuous throughout the resuscitation you have to monitor the hemodynamic parameters. The basic parameters, heart rate, respiratory rate, blood pressure, and you have to use if the facilities are available, lactate. The lactate levels in the pediatrics, the lactate level doesn't say itself doesn't say the severity of the septic shock. If you say if the lactate level is 6, we can't say patient is having severe septic shock than if the patient is having lactate level 2. So the recommendation is you have to use lactate trends to see the resuscitation adequacy. If the lactate is coming down with your resuscitation, it means your resuscitation is optimal. You use the lactate levels, the trend, to manage the patients. And in the ICU, we have the other facilities, the advanced hemodynamic facilities. We can give the invasive blood pressure monitoring and cardiac output, the echocardiography, and we are using the mixed linear saturation for guide the resuscitation. Like that, we have advanced monitoring. But in the ward setup, if you manage the patient, you have to do the continuous monitoring of these basic vital signs. Time, is it important? Time is very much important. That's why the pediatric patient most are dying, because In the first hour, you have to do all the fluids and start vasopressin. If you not manage in a timely manner, then what happens? The irreversible organ damage occurs and multi-organ dysfunction occurs and patient dies. So time is very much important. If you early identify the risk patient, then you have to do the fluid resuscitation in a timely manner. Then about antibiotics, when and what antibiotics to start. So I'll go to the recommendation. If the patient is sepsis with shock, you have to start the antibiotics within 1 hour. If the patient is sepsis with no hypertension, then you can have time to start antibiotics. You can start within 3 hours of recognition. You have to take blood cultures before antibiotics if possible, and you have to start empiric broad spectrum antibiotic. Monotherapy is ideal in pediatrics, but if the patient is having underlying any high risk categories, or if the patient is having immune deficiency, then they recommended to start empiric multi-drug therapy. These are the antibiotics that I use in my PICU. So we usually use the ceftriaxone as the first one. If the patient is in the ward or if there is any evidence of nosocomial origin, we'll add vancomycin, and if the patient is suspecting encephalitis, then we add acyclovir. Depending on the patient, the clinical patient's history, we change the antibiotic. We start the antibiotics. Then antibiotic stewardship in pediatrics. Once the pathogen and sensitivity identified, then you have narrowed down the antibiotics, and always you have to do the daily assessment to re-escalation of the antibiotics, and the duration and stopping of the antibiotics depends on the response to treatment as well as the patient's clinical background as well as the organism. Then when to start vasopressors. Vasopressors are indicated in the fluid refractory shock, as I explained. What is the first line vasopressors in pediatrics? The first line vasopressors in pediatric is either adrenaline or noradrenaline, not the dopamine. Dopamine has lot of adverse effects. That's why it recommended the first line vasopressors in children are the adrenaline and noradrenaline. But in literature, there is no comparison between adrenaline and noradrenaline in pediatrics. So, mainly the vasopressors we have to select according to the patient's hemodynamics and according to the patient's physiology. If the patient is having low cardiac output state, we can start adrenaline because adrenaline is also having the inotropic action as well. If the patient is having shock with vasodilatation or low systemic resistance, then you can start with noradrenaline. So I have to highlight the pediatric first line of vasopressors are adrenaline and noradrenaline. You have to select either of that depending on the patient's characteristics. These are the literature. It clearly says if you use dopamine as a first line, it increases the death and healthcare associated infection as well. And also adrenaline is associated with increased survival as well. So usually in my PICU, always we start adrenaline as a first line. And this is the other article. It also says the adrenaline is very effective than dopamine in resuscitation and improving multi-organ dysfunction. The adrenaline is more effective than the adrenaline. Then the important thing, most of the children need transfer to the ICU. Most of them coming from the long distance, especially in children PICUs. So vasopressors, can you give it peripherally? The answer is yes. You can give any vasopressors in a dilute form in the peripheral line or even in the intraosseous line. There is a systematic review or meta-analysis done in the adults and pediatrics both. It clearly says it can be safely used. It can be used even during transport. What is the problem with peripheral vasopressors? Peripheral insert vasopressors. The main problem is the extravasation and necrosis and edema. But they found it is nearly 2 to 3%. So that's why it is recommended to start vasopressin from the peripheral line. But there are some risk factors of extravasation or adverse effects with vasopressors. So if you have a kid less than 1 year, if the child is having small cannula, then if the IV site is in hand, it is not good for starting peripheral cannula. You have to select a large vein and you have to use the proximal vein to start vasopressors. And if the vasopressis is going for more than 3 to 6 hours, it's better to start insert a central line as well. If the transfer takes more than 3 hours or 6 hours, it's better to put insert a central line as well. Always you have to do the dilution before giving the vasopressors to the peripheral line. What are the blood pressure goals in pediatrics? The recommendation is you have to maintain the map between the 5th to 50th centile, and you have to check other organ perfusion parameters as well. In resource limiting setting, you can go with the systolic blood pressure by systolic blood pressure. Then we look out what is catecholamine resistant shock. The catecholamine resistant shock is if the patient remains hypotensive even with the fluids, even with the maximum dose of catecholamines, if the patient remains shocked, it is called catecholamine resistant shock. Then you have to think of the adding vasopressin or the inodilators. Vasopressin in pediatrics, it causes more side effects. It causes more ischemic effects. Actually, if you add vasopressin at the end, it normalizes your parameters, vital signs, heart rate, all are normalized. But patient, there is no survival. The studies show there is no survival benefit in pediatrics of vasopressin. Or if you have any evidence of low cardiac output state, then you can add the milrinone. Milrinone is a good inodilator, and you can add milrinone if you face the patient with the catecholamine resistant shock. Then if all the measures, fluids, adrenaline, noradrenaline, vasopressin, milrinone, with all things, still patient remains hypotensive, then you recheck your diagnosis. Is it a septic shock? Then you should look for the alternative diagnosis. It may be pericardial effusion, which obstructs the contracting heart. If you do anything, the heart is not pumping blood to the perfusion. And it may be pneumothorax, and it may be underlying adrenal insufficiency, it may be underlying hypothyroidism, and sometimes there may be sometimes ongoing bleeding, and sometimes the primary focus may be remain, the wound, intra-abdominal abscess may be remain. So you have to first correct that for the patient's survival. The steroids, are they indicated in pediatrics? There are two indications in pediatric septic shock. So if the patient is not improving with your fluids, the catecholamines, then there is a place for steroids, but it is not recommended, but you can use. It may or may not be used. Okay. So there is a place for steroid if the patient is having catecholamine resistant shock, and also if you suspect the patient is having underlying adrenal deficiency. If the history of long-term steroid use, if the history of adrenal disorder, then there is a place for steroid use. And also during resuscitation, the investigation comes as persistent hypoglycemia, hyperkalemia, hyponatremia, and there is also place for steroid, because as I mentioned in the septic shock, all the organs will be less perfused. If it less perfused the adrenal medulla, adrenal, it causes the adrenal insufficiency. So the treatment is steroid. You have to think of this hyperkalemia, hyponatremia, and the hypoglycemia. You have to give a steroid dose. to improve the patient. Then how to decide on the intubation. So during resuscitation, if the patient found is developed any these problems, the patient is having respiratory failure, or if the patient is having any compromised airway, or if the patient is losing consciousness during resuscitation, or if the patients develop any features of heart failure, fluid overload, then it is the time for the intubation. What is the problem with intubation? Intubation is septic shock. Is it safe? No. The induction agent that you are using for the intubation, most of them are causing vasodilatation. The propofol, the midazolam, all are causing vasodilatation. The patient is already having shock. If you give induction agent, patient may go into the cardiac arrest. And also, when intubation, then we connect to the ventilation. So what happens in ventilation? We are usually ventilation, negative pressure ventilation. But when it turns to the, when you connect to the ventilator, then it turns into the positive pressure ventilation. What happens in positive pressure ventilation? In positive pressure ventilation, it increases the intrathoracic pressure. So what happens with increased intrathoracic pressure? It reduces the preload. That's why then therefore it reduces stroke volume. So if you change the patient into the negative pressure to the positive pressure ventilation, patient might collapse during intubation and ventilation. Therefore, it is recommended to give fluid bolus before intubation, because the fluid is necessary to maintain circulation. This is I explained before. The propofol is currently not used in pediatrics because it can cause fatal metabolic acidosis, and also the benzodiazepines is not recommended. There is no any recommended data of the induction agent, but the safe induction agents are the ketamine and the low dose fentanyl. The ketamine has advantages because ketamine increases the blood pressure, and it also having bronchodilatory effects, and also the problematic side effects is the secretion, but secretion can be manageable. So if you need to intubation septic shock child, you use the ketamine and fentanyl. A ventilator setup, it depends on the patient's characteristics. If the patient is having fluid overload, then you have to select the high PEEP, and if the patient is developing pediatric acute respiratory distress syndrome, then you can do the prone ventilation. Likewise, ventilation is depending on the disease, the main organ involved. If the patient is having more involvement in the central nervous system, then you have to do the neuroprotection ventilation as well. It depends on the disease. You have to do the disease specific ventilation in this sort of septic shock patient. Nutrition, you have to use the enteral nutrition. Don't withhold the enteral nutrition because of the vasopressin. It is recommended to start early nutrition and increase in stepwise manner. And parental nutrition is not indicated in the first 7 days of admission, and also they are not recommended to routine use of prokinetics, not recommended to normalize the vitamin deficiencies. So then the important thing, how do you give organ support? As you all know, the patient will die of the multi-organ dysfunction. Throughout the resuscitation process, always you have to keep an eye on every organ in the body. Okay, so we can use some screening tool to identify which organ is more damaging, more getting insult. There's a score called Pediatric Sequential Organ Failure Assessment Score, PSOFA score. It gives a idea of which organ is more involved. If this score is more, it says patient has more multi-organ dysfunction. If the total score is less, it says there is a little bit there's a less multi-organ dysfunction. Depending on the severity of the multi-organ dysfunction, we can manage the patient. If you assume the patient is having the high scores in the renal system, then child will need the CRRT or peritoneal dialysis at one time. So you have to anticipate the problem beforehand, then you can act on it. If the patient is having any respiratory problems, so in my unit, usually if the patient's blood gases PF ratio is less than 150, I electively intubate septic shock patients, because the evidence says if the PF ratio, I think you are aware of that PF ratio, it is less than 150, it is beneficial to intubation in septic shock patient. So like that, this screen tool is very much important in managing organ support in patient with septic shock. So the organ support as are these. The respiratory system is more involved, you need ventilation. The cardiovascular system is more involving, you have to do the iron drops. The renal system is more involved in the septic shock patient, then you have to decide on the peritoneal dialysis and CRRT. The central nervous system is more involved, you have to do the neuroprotection. Electrolytes and blood sugar, you have to maintain all the electrolytes normal, and the glucose, there's no recommendation of the tight blood glucose maintained. And the calcium you should maintain above 1 millimoles per liter, because calcium is essential for the cardiac contractility. So calcium is very much important in septic shock management. And blood, is it worth in pediatric septic shock? As you know, the main goal is to maintain organ perfusion. We have to maintain organ perfusion with good oxygen. For that, blood is very much important in septic shock management. So if the patient is hemodynamic is stable, then you can decide of blood transfusion if the hemoglobin drops below 7. If the patient is hemodynamic unstable, you can think of blood transfusion in the hemoglobin drops less than 9 grams. Okay, then FFP and platelet. The FFP, the prophylactic FFP transfusion is not indicated if the absence of any bleeding, or if the INR less than 1.5, the prophylactic FFP transfusion is not indicated. But there is a place for platelet transfusion. If the patient is having platelet is less than 10,000 with evidence of bleeding, even with the absence of bleeding, you can consider platelet transfusion in pediatric septic shock patient. If the patient is having coexisting bleeding, even with the platelet count less than 50,000, you can consider the blood transfusion. You can consider the platelet transfusion. Okay, is there any place for IV immunoglobulin in children with septic shock? The routine IV IG is not recommended. If the patient is having underlying toxic shock syndrome, or if the patient is having necrotizing fasciitis, or if the patient is suspecting of having underlying humoral deficiency, then there is a place for IVIG in pediatric septic shock management. Then if all the measures fail, then we have to move on to the advanced therapies. There are 2 advanced therapies available. One is the CRRT, which is available in our PISU, and ECMO is not available. So if the patient is having fluid refractory shock and with severe acute kidney injury, and if the patient is having severe lactic acidosis, and there is a place for CRRT. ECMO, if the patient is having oxygenation problem, then you can refer to the ECMO. And the last slide, do I need to adhere to the guidelines? Actually, in the ward setup, yes, because the early septic shock usually occur in the wards. So you have to adhere to guidelines to optimize the patient. Otherwise, patient will go into the multi-organ dysfunctional refractory shock. So, but in ICU, most of the time we are receiving the patient with multi-organ dysfunction. So we are not adhering to the guidelines. We are mainly managing individualized management. So especially the organ support. So in the ward setup or early septic shock, you have to adhere to the guidelines to better outcome of the patient. Summary. So this is summary that I discussed so far. The early recognition, the rapid IVIO access, you have to get blood culture, then early broad spectrum antibiotics, then you have to use the lactate trend to identify the resuscitation as a resuscitation guide, and then the crystalloid, then the adrenaline, noradrenaline, then hydrocortisone. These are the main things of the resuscitation of the pediatric septic shock. So take home message is an infection, if unnoticeable, turns into a unstoppable. You have to take this home message, because if you can't find the if you can't recognize sepsis, child might die. Okay. Thank you.
Thank you, sir, for the informative talk and emphasizing the life-saving important points in managing septic shock in pediatrics. Now I would like to invite Dr. Shamini Jayakali, consultant pediatrician of TC Hospital, herein, to give a various certification of appreciation to Dr. CND there. And now the floor is open for questions to be asked from the speaker. Okay, thank you, ladies and gentlemen. We shall now move on to the fifth and final session for the day, titled as Pathfinder for Bugs to Fight the Sepsis. The speaker for this is Dr. Rohini Vadanambi, the President of Sri Lanka College of Microbiologists and the consultant clinical microbiologist who currently heads the microbiology department at Lanka Hospital. Dear Madam, the stage is yours.
Thank you very much, all the organizers from the KSM, as well as the one who invites me, Dr. Mudita, and all the colleagues whom I'm meeting. I'm very pleased to come here and stand in front of you to deliver a lecture on Pathfinder for the bugs to fight the sepsis. So you heard a lot of things how you fight the sepsis. So let's see what I can do justice to that. Yeah, trying to understand the sepsis is it's like trying to smell the color. So everyone was trying to tell that diagnosing and managing his sepsis is very difficult. So it is so, but still there are ways we still can try. Time to needle matters. Everyone said that it's less than 2 hours, otherwise you will end up somewhere. So once A, B, C, D, E looked after, run the broad spectrum antibiotics and see for the clues. So my effort is to help you to find out some clues, at least to reduce the spectrum, not always broad spectrum. So you can use all these sepsis guidelines starting from SIRS and then QSOFA, SOFA, PSOFA, and so many American guidelines to find out scores. And all of those, following all of those, you are trying to save a life. So in that case, same time I have to insist as a microbiologist, using broad spectrum all the time. To life saving, it doesn't matter. But without sepsis also people are using broad spectrum all the time. So try to understand using all sepsis scores as well as excluding inflammatory processes other than sepsis, and then use more suitable antibiotic. You need experience and you need some kind of intuition which you get as you go on. In Sinhala we call Iva. We need to have that as well, in addition to when you follow all these guidelines. So in my experience along this line of microbiology, that's the initial message I want to give. Then I will try the rest that I want to tell you. So we all are aware that there's a crossing in between SIRS and the sepsis. So the in between there is a overlapping, but there are a lot of other causes lead to shock, like trauma, burns, pancreatitis, and even heat can lead to shock, and people can die. But and no need of antibiotic. But other causes, all these infections caused by bacteria, majority of them, and then fungi, parasites, and viruses, and several other the microbes can do sepsis going into severe form. So actually, this chronological order is towards a symmetry if you do not do this management of going into septic shock. You have to manage it at the level of very early sepsis, and then you have to diagnose whether it is going into severe sepsis and then stop at that point. And then during septic shock, still at early stage, all speakers before me told you how to manage it without allowing the patient to die. After that, you can't stop. When the patient went into the refractory septic shock, they end up in symmetry. So under my efforts, I will tell you how you get a patient coming in sepsis. If that patient is having a infection of the dermis, a condition called erysipelas that you see in this picture, you don't have to use a broad spectrum. It is almost always by a bug called streptococci, out of which mostly group A and B, C, G also can do that. It is streptococci. Penicillin alone can help you to prevent this patient going into the symmetry. So the second one, impetigo. So impetigo can, there are two main different ones. Let's see those pictures. This is a non-bullous form. It is called honey crust, caused by Streptococcus pyogenes, group A, strep. So this picture mostly you see among children, and the bullous form of the impetigo, it's Staphylococcus aureus. So these pictures and early sepsis features, you don't have to worry. You straight away can cover both of these, because sometimes mixture of bullous and honey crust can come together. That is staph and strep together. So you can combine. Either you can give penicillin alone for strep and cloxacillin for staph, but flucloxacillin alone can, it's the better form of absorption and penetration of cloxacillin. You can save this patient from both. So, and the next one, so this is the bullous form of the which is caused by staph. Next one, it is folliculitis, infection of the hair follicle. So that again, Staph aureus, right? This Staph aureus is very nasty, can cause folliculitis, severe forms also. And this folliculitis, even these infection can lead to shock based on the toxin production. Then the boils, again staph infection, it's a deeper part of the hair follicle. Then what is the upper part of the hair follicle? The superficial part is the folliculitis, then the upper part was, let's go back, upper part is folliculitis, deeper part is boils. Boils is again the combination of furuncles. It is called furuncles, combination of folliculitis, a bigger form, several of those. And the carbuncle again, it has involved in the adjacent hair follicle, and then going by another, several will be combined together. All these done by Staph aureus. Ecthyma, again staph and strep both are combined. So with these pictures, when the patient presents, you can identify what is this, and if the patient is very septic, you can straight away start the treatment for staph and strep together. Cellulitis. So again, this cellulitis also, it can be done by normal skin flora in certain instances, and maybe exogenous bacteria. This Staph aureus and beta hemolytic can be normal flora among some people. and that can be hospital acquired for some people, some or in community acquired infection from the daycare centers and schools. This can be happen. However, for cellulitis, you need a kind of trauma, ulceration, or breach of the skin, and then the bugs who entered, either staph or staph, beta hemolytic staph or both, it can go along the soft tissue. If it is penetrating the fascia beyond the soft tissue, the name given necrotizing fasciitis. So at cellulitis stage, people can go into shock. This is cellulitis form where this toxin spread along the lymphatic drainage system involving lymphadenitis and lymphangitis. Necrotizing fasciitis means it penetrates the fascia, and both staph and strep can do the bad influence on the subcutaneous tissue. This is a surgical emergency. You have to very quickly, very fast, you have to start treatment and carry on saving to save the life or save a limb or save a part of the body, because it needs massive the surgical debridement to stop spreading. Then again, another infection by staphylococcal, that is called staphylococcal scalded skin syndrome. It destroys the dermis of the, especially we see this among babies, dermis of the patient, and it's very painful and can go into shock very easily. So it is Staph aureus is the culprit. Hidradenitis suppurativa, again involvement of your sweat glands, mostly in the wet flexures like axilla, perineum, that can give rise detrimental events if you do not identify. So that again Staph aureus. From the soft tissue infections, let's move on to infections of the bone and joints. First we will deal with osteomyelitis. There again, these infections can caused by bacteria, fungi, parasite and viruses, but mostly bacteria. So under osteomyelitis, we have categorization or kind of classification based on duration, very fast onset one, acute, subacute or chronic, and based on route of infection, hematogenous or exogenous, and based on host response, pyogenic or granulomatous. So etiological wise, for in infants, when it is coming as osteomyelitis, Staph aureus, Streptococcus agalactiae, which we called group B strep, E. coli are the commonly identified organisms. And in children over 1 year of age, you get again Staphylococcus aureus, Strep pyogenes, that's group A, and Haemophilus influenza. And adults, mostly you get Staph aureus as the first organism. And again, there's another clue that you can get based on when there is a culture, when there is a single pathogen isolated, more likely it's a hematogenous one. When it is a multiple organisms are involved osteomyelitis, it's direct inoculation through trauma, penetration or accidents, or from the nearby tissue, it contiguous focus of infection. And further to organisms isolated in bacterial osteomyelitis, when staphylococci are involved, organism most often isolated in all types of osteomyelitis. Most commonly, Staph aureus can be isolated. And when the organism is coagulase negative staphylococci or propionibacterium species, these are kind of coagulase negative is there are about more than 35 to 40 species newly identified, other than the one whom we knew as Staph epidermidis. There are several other Staph are involved, where there are a lot of other sophisticated identification systems like Vitek or Molditov, we can get to know those species as well. Such organisms are involved when there are foreign body associated in the joint. Then the Enterobacteriaceae species like all these E. coli, Klebsiella, Proteus, and every other Salmonella, all those are Enterobacteriaceae species. Then Pseudomonas, those two, when those two are involved, it's a kind of nosocomial infection and punctured wounds, surgical, post-surgical infections, or post-surgically acquired hospital infections. And when streptococci or anaerobic organisms are involved, that can be associated with human bites, fist injuries where the teeth are involved. When somebody hits somebody's face and teeth are involved, that person can get osteomyelitis of the fingers. Those are some injuries that we can, because these clues will help you to decide based on the sepsis what to go rather than giving huge broad spectrum ones. Diabetic foot lesions also you can get anaerobic involved. Those steps may be different, maybe not oral steps, but the gut streptococci and decubitus ulcers also. There are instances you get Salmonella species or strep pneumoniae in certain osteomyelitis cases where the patient is having sickle cell disease, diagnosed to have sickle cell disease. And now most of the clues I gave, Staph aureus is involved. So let's have another separate aspect of this staph. Why is it so much involved in sepsis? It has it is an element of a normal skin flora. So any time if that guy wants to do a sepsis, it is available in our skin, and it increases affinity for host proteins. So when there is the trauma in the skin, most of you males must be knowing, when you scrape accidentally when you shaving, in the afternoon you will see a yellow dot. That's staph. Anybody who had a minor scrape on your skin, you will see a yellow bud coming up in the evening or the next day. That's again staph, because that's the affinity of staph towards our, though it lives harmlessly on our skin, it becomes a normal flora, normal microbiome of our skin, but it can anytime opportunistically attack our tissues. So it has so many array of enzymes, like it has coagulase, surface factor A, and there are several other protein dissolving enzymes in his armories to attack us. So that those things can hamper host immune response. So easily it can start severe sepsis. It has L forms, which are called dormant forms. It can be dormant somewhere in our tissue for ages, just like TB. L form is inactive. It doesn't divide. It doesn't breathe or anything, but just living, kind of hibernizing form. So that means anytime given the opportunity, it can act upon. And it can produce biofilm, another very bad form of living form of the staph. Not only staph, there are other organisms also, which is nowadays we use several prosthetic things, artificial things to elongate our lives. And so they can go and have a biofilm is a kind of continuous life of these organisms, hiding from the host immunity and developing their own crust or wall made out of all these polysaccharide slime layers, and then that layer will not be able to penetrate by most of the antibiotic we use, even though nowadays all these research and developments are trying to find out biofilm penetrating antibiotic, but they are in very few in number. So that ability also give rise a massive ability for this bug to kill us. And also there are large variety of adhesive proteins and glycoproteins produced by this organism, which mediate binding with especially bone components. I mean, I took this slide under bone because Staph aureus is having almost everything which is effectively affect our bones and the prosthesis to cause infections. Then this acute pyogenic osteomyelitis picture, I'm showing the places. Hematogenous ones are more towards the joint, and direct spread is somewhat below, and exogenous one are anywhere periphery. Then septic arthritis. It's an inflammation of a joint due to bacterial or fungal infection. It can be, again, there are infectious arthritis, bacterial arthritis, and non-gonococcal bacterial arthritis. That means there are, under infectious one, gonococcal ones also included. And in this acute septic arthritis, there are different forms that you can find out. 50% of cases among less than 3 years. Hip joint is the common site in less than 3 years. The knee joint is more common in older children. So the septic arthritis related severe sepsis or going into bad form of sepsis, you can determine, you can take these clues in addition to the bug's name. So these bugs like Staph aureus, Strep pyogenes, E. coli and Haemophilus influenzae are, I told initially, are common in children as well as elderly population. Chronic septic arthritis, less common, but still it's not that less in Sri Lanka because we have TB. So a lot of people end up coming in activated TB which were dormant for some time and come up with septic arthritis, commonly spinal bones and rarely in other bones also. Candida albicans also seen, even I have seen several cases coming as septic arthritis. Even without diabetes, I have seen Candida albicans in a joint of a young person's finger. I mean the finger, joint of a finger, because that one biting nails. So it's easily Candida entered into the, without even diabetes or any immunosuppression, Candida was there. So next is that I'm going to touch is central nervous system infections. That again, hematogenous pit, direct implantation, local extension are known ways that can happen. And acute pyogenic ones, which are called bacterial ones, etiologically among neonates, we have to consider E. coli, Strep pneumoniae, Listeria monocytogenes. And adolescents, we have to consider Neisseria meningitidis, Haemophilus influenzae. And acute aseptic, under that condition, we have to consider, that's actually a misnomer calling aseptic. It's a viral, commonly viral. So these testing and things you will know, but the organism wise, I'm talking about those organisms to help you, because otherwise it will be another route that I have to take. Acute focal suppurative infection in the CNS, brain abscess, is another common thing these days we are finding. I have seen several, even recently there was a child who was diagnosed at early stage to have a pulmonary atresia, which they have done some dilatation and managed that child, followed up for several years, up to third year, I mean up to second year after following, child was asked to come 1 year later, and before that next 1 year, at 3 years of age, this child came up with the meningitis symptoms. And before doing the LP, they did a scan to see that there was a large cerebral abscess, currently treating. So, so that kind of things can happen. It's not uncommon. there are a lot of elderly people who diagnosed as meningioma. Sometimes it appears when they operate it out, appears as sepsis. So we need to know that as well, because those etiological clues will help to say if they are totally, either they will go end up as disabilities or sometimes severe sepsis. So need to know them. So background history of like primary infected site in the heart, or acute ones you can have, either bad tooth and decaying problems, bone problems also can lead to brain abscesses. Strep and staph are the most common, but anaerobic ones are also involved, coming from mostly from the oral flora. Let's talk about the respiratory tract infections and how severe sepsis coming from respiratory tract, we can finding the clues how we can deal with them. So among the upper respiratory tract infections, otitis media. So etiologically, strep pneumoniae 20 to 35%, non-typable Haemophilus influenzae 20 to 30%, Moraxella catarrhalis 20%, Staph aureus again, strep pyogenes, Pseudomonas, viral 44%. So knowing these things, you still can handle when a middle ear infection leading to severe sepsis come into play. And among the upper respiratory tract, sinusitis again is a problem, where etiologically strep pneumoniae, H. influenzae, strep pyogenes are involved. Nosocomial sinusitis is also a common thing acquired in the hospital, especially critically ill patients where there are a lot of tubes going through the nose and the like NG tube, and when they are mechanically ventilated, they can acquire a lot of other bugs in the hospital. They still can have their own flora like Staph aureus, Moraxella catarrhalis, and from hospital they can acquire Pseudomonas, Serratia, and even other bugs like Klebsiella and fungi also. Pharyngitis. So this acute pharyngitis, you have this list, like mostly you have viruses, rhino, corona, adeno, herpes, influenza, parainfluenza, and Epstein-Barr. Under bacteria, so always this major portion goes to viruses in the pharyngitis. So when the bacteria are involved, they are like group C and G, A, C, G, all three are involved, Streptococcus group, and Corynebacterium diphtheriae, Neisseria gonorrhoeae, Mycoplasma pneumoniae, Arcanobacterium hemolyticum, Yersinia enterocolytica, and Chlamydia pneumoniae. So these organisms are involved. Some of these can diagnose clinically, and you can do it with the bacteriological support. So all the sepsis management, the speakers told you when to start culture. So I'm not going to stress on that. I enjoy that you all are doing it before antibiotic. Everyone is advised to do so. Please do it that way, and stick to use your clinical knowledge and take appropriate samples whenever necessary, and then to step down your broad spectrum, use that information precisely. And under lower respiratory tract infections, bronchitis, bronchiolitis, and pneumonia comes under. So etiologically, bronchitis you get, I mean, it's a seasonal one, mostly not in Sri Lanka, but even in Sri Lanka there is a seasonality for influenza and parainfluenza. And cold, damp climates like this weather, you may likely to get Mycoplasma pneumoniae and chlamydia also, Chlamydia pneumoniae. And the Bordetella pertussis, it is spreading among the community, and especially among schools and the nurseries. Common cold viruses also spreads among the crowds. Other pneumonia causing strep pneumoniae, other streptococci, staphylococcus, and Haemophilus, they are sporadically you may find. Some of those can spread from person to person as well. Bronchiolitis. This is mainly a virus, so very rarely you have secondary bacterial infection. So it has to be managed as for viruses. Should not give antibiotic which can worsen the condition. The proper lower respiratory tract pneumonia is an inflammation of the lung parenchyma associated with consolidation of the alveolar space. Etiologically, among neonates, you have to consider mainly group B strep, E. coli, Klebsiella, Staph aureus. Infants, pneumococcus, chlamydia, RSV, H. influenza type B, and children 1 to 5 years, RSV, pneumococcus, H. influenza type B, and chlamydia trachomatis, mycoplasma pneumoniae, Staph aureus, group A strep. Children 5 to 18 years, including adults, mycoplasma pneumoniae, pneumococcus, chlamydophila, H. influenza type B. So with the vaccination, H. influenza type B infections are somewhat under control, and there are some antivirals for some of these viruses, but rest you can diagnose with the help of the age group and the clinical presentation and the radiological and other imaging support, and with your experience and the guideline. Type of pneumonia, there are several names given: community acquired pneumonia, healthcare associated pneumonia, pneumonia among HIV patients, pneumonia in neutropenic host, hospital acquired pneumonia, and ventilator associated pneumonia, atypical pneumonia like all that mycoplasma and chlamydia, those things are called atypical pneumonia. And Legionella pneumophila is another different variety of pneumonia with classic symptoms associated with AC and all. Chlamydophila, again, atypical pneumonia. The viral and TB associated pneumonia, and SARS, H1N1, avian influenza. I mean, nowadays, corona, corona also, we can add it into that list. Next, we'll move on to urinary tract infection. The upper urinary tract and lower urinary tract, we divide into major two categories. Cystitis, the lowermost cystitis and urethritis are called lower urinary tract. Acute pyelonephritis, chronic pyelonephritis, interstitial pyelonephritis, and renal abscess are called upper urinary tract infections. Under those, the causative organisms are that most often the enteric bacteria cause infections. 75 to 95% cases is E. coli. Klebsiella proteus and Pseudomonas are also involved, rest of the percentage. Gram-positive bacteria, Saprophyticus, is associated among 5 to 10% of bacterial UTI. Enterococcus faecalis, it's a group D strep, also associated to a certain degree. Streptococcus agalactiae is associated to another considerable portion. In hospitalized patients, E. coli accounts for about 50%. Gram-negative species Klebsiella proteus and Proteus Pseudomonas serratia, another 40%. Gram-positive bacteria like Enterococcus faecalis, Saprophyticus, Staphylococcus aureus account for the remainder. So these associations based on the colonization of the patient, the perineal colonization and the flora of the gut associate with the type of UTI the patient is getting. In instrumentation associated, surgery associated, and the catheter associated will be little different. Then I'll move on to the gut infections, GIT infections. This is the cholera. I will rush through because of the time factor. You all had 3 long lectures and I don't want to drag you into a kind of tired mode. So this is a picture motion of identification. This is Vibrio cholera. I took this because nowadays in Sri Lanka you don't see much Vibrio cholera, but there are some the Vibrio you will see among fishermen and the seafood associated and meal associated cholera types, not Vibrio but other types, food poisoning type of ones. Actually, the world, among the world pandemics, cholera had a 6th pandemic, and we are still in the 7th pandemic. It is not over because majority of cholera pandemic ones are in the Indian subcontinent. So being in the neighborhood, the closest neighborhood, we are not that unfortunate to have cholera as much as they have. But it's good to know cholera also. So diarrhea causing E. coli. I mean, we always think E. coli is doing, the urinary tract infection and things like that. But there are several specific E. coli which can cause food poisoning and the diarrheal diseases. Even toxigenic ones can cause death. Enterotoxigenic one, it has a watery diarrhea, but it can cause severe form of sepsis. It lives in the intestinal lumen. Enteroinvasive E. coli, it invades intestinal wall and it's a kind of dysentery, the blood and mucus diarrhea. Enteroinvasive E. coli, some varieties can cause shock again, a severe form among children also. Hemorrhagic E. coli, it does not inward, but it can cause bloody diarrhea. Enterohemorrhagic one has a toxin that cause colitis also. Enteropathogenic E. coli, it causes infant watery diarrhea and can give nasty dehydration also, and that will lead to shock as well. Then the salmonella, among the gut infections, salmonella again, salmonella lives in Sri Lanka quite for several decades among us. So most of us are having antibodies against salmonella, but salmonella, different varieties are there. About nearly over 100 strains are there, different numbers and different names. All of them can, most of them can cause diarrhea, and some are invasive, some are systemic problems, some are causing severe systemic forms of disease based on its toxins, as well as when the patient is immune suppressed. Shigella, it is known to cause bacillary dysentery. Again, there are several different strains. Some of them are like causing infection similar to amoebic, parasitic amoeba like infections. Some of the Shigella ones are like Campylobacter like infections, invasive E. coli types also. They are mimicking, so you can't distinguish other than the culture or serological tests also there. Entamoeba histolytica, trophozoites again can cause different forms of infections. That again, the dysentery kind of blood and hemorrhagic blood and mucus diarrhea and severe abdominal pain. This is again throughout the year in Sri Lanka, time to time we see among patients samples, stool samples. Another new thing about, new in the sense this was known but not fully attention given, there are invasive and non-invasive amoeba 100% similar to each other. One is called Entamoeba dispar, the other one is called Entamoeba histolytica. You are unable to differentiate them with the test you have. So if somebody is isolated Entamoeba histolytica trophozoite or the cyst, you have to trust the clinical ground before treating. Quite often our people test for this when there are clinical signs and symptoms. So then you may have to treat, but coincidentally if somebody has found like healthcare checks or something, you should not have to treat. It may be the non-invasive type. Clostridium difficile is also a very important one when we talk about antibiotic, because antibiotic can cause Clostridium difficile selection, and the Clostridium difficile toxin producing strain can fast cause the death of the patient. Fortunately, in Sri Lanka, Clostridium difficile toxin producing strains are very little we find. Earlier we thought because of the lack of diagnostic kits and diagnostic tests. Now here and there we have these diagnostic facilities, but our isolation rates is less when compared to the amount of antibiotic we use. That's a lucky part of Sri Lankan genetics. So the list of antibiotics associated with C. diff infection, better to know, like all these cephalosporins, third generation, fourth generation, and ampicillin, amoxicillin, clindamycin, and fluoroquinolone, and all these are highly associated with, among countries where there are high incidence, those are the highestly associated with. I am not telling we never have, but we do have, but less common and less deadly. I haven't seen a death due to C. diff infection in Sri Lanka in my career, during my career. The occasionally associated with macrolides and cotrimoxazole, rarely associated with vanco, metronidazole, tetracycline, amino glycoside, flyfluorouracil, and methotrexate and cyclophosphamide. Actually, when you get the C. diff infection, the treatment is vancomycin and metronidazole, oral vancomycin and oral metronidazole. That oral vancomycin is not available in Sri Lanka, only IV forms. We still found a way to use it whenever necessary. So place of cultures, just before that, I don't have a slide, but I want to mention CLABSI, central line associated bloodstream infection. That's another major portion of infections among hospital infections, where we have severe septic patients and die because of the unidentified severe sepsis of CLABSI. So that is also you have to remember. We are about to start a CLABSI surveillance from Sri Lanka College of Microbiologists, and Kandy Hospital are also participating in that surveillance. So subsequently, with those results, your two microbiologists will convey to you the message we want to share. So regarding the place of culture, do not give up. Always try the culture, because if you fail to get it before antibiotic, very early in the antibiotic, you can take the cultures. I will tell you the positive percentage rates for you to understand how much we can help. The samples that you can take are like blood, tissue, pus, CSF, as any kind of aspirate, biopsy, bone marrow, or any matter that you think will helpful to diagnose a bug. So these are the rates. Blood culture in general would help. When there is a severe sepsis patient, there's a 20 to 40% chance of isolating a bug. When the patient in septic shock, there's a 40 to 70% positive rate. So 40% of them are like gram-positive bacteria, 35% gram-negative, 11% polymicrobial, 7% fungi, less than 5% classic pathogens. That's why I told you, when you choose broad spectrum to 100%, it's not right. This slide shows you when you choose antibiotic, you don't have to cover everyone, but you have to very confident to reduce the broad spectrum into the narrow spectrum, because you need to have 100% judgment, because the needle time is also very important. So, but never give up. Try to be that confident and knowledgeable. So this is again just to sum up the virulent factors of bacteria. They have antioxidant enzymes, hemolysins, exo and endotoxin, exopolymers, and all these are reducing our, hampering our immune system function and evade our ability to engulf them, and they do several lysis of our tissues and damage our response system, damage our cardiac tissue, all our major organ tissue. So therefore these are our enemies actually. Different forms formation like planktonic, L forms, encapsulated forms, biofilm fragmentation, all these are survival forms like camouflaging. Capsular polysaccharide is also very important because it evades all our fight against them. Biofilm, just like biofilm. Survival against phagocytosis is also another mechanism, like TB-like bacteria survive, and surviving against antibiotic is by producing anti-antibiotic like complex chemicals. All sepsis causing bacteria like Staph aureus, Strep pneumoniae, Haemophilus influenza, Neisseria meningitis, Klebsiella pneumoniae, E. coli, group B strep, all of them have polysaccharide capsule. Therefore, considerably they decrease the ability of antimicrobial agents to gain entry into the cell where the drug targets are located. So then useless we are using our antibiotic or antimicrobials when they are, ready to cheat us. So another one point, several studies done in Western countries found out pre-hospital resuscitation. They call pre-hospital resuscitation is emergency unit or GP. We don't have a proper GP system in our country, so it is emergency unit. The reduction, 35-minute reduction was achieved by initiation of antibiotic at pre-hospital, the emergency unit, and 41-minute reduction to targeted sepsis resuscitation. So if those two can be started at the emergency level, it reduces the death rate. So we need training our emergency people towards that. Not until come to the ward. It may be so late, and during transfer also we may lose our chances of saving a patient. If you are not tired, can ask questions. I am not tired to answer though.